Good afternoon. I, Dr. Rizwana Habib, extend warm welcome from the beautiful snow-clad Kashmir Valley to the faculty, esteemed teachers, esteemed colleagues, and dear postgraduates from all over India who are attending this Obstetrics and Gynecological Teachers Tutorial, a brainchild of Professor P.C. Mahapatra. We are hosting, we from the Department of Obstetrics and Gynecology, Government Medical College, Srinagar, are hosting this tutorial on today, 19th of November, 2020. We are representing the North Zone. And this is such a great tutorial and a great brainchild of Professor P.C. Mahapatra, because in these COVID times, when the teaching has gone far behind, this is so good to have such type of teaching and postgraduate teaching. Now I invite Professor Farhad Jabir, head of the department of our Department of Obstetrics and Gynecology, Government Medical College, Srinagar, to give introduction for today's tutorial. And the tutorial is on high-risk pregnancy.
Good
Professor Farhad is an excellent
afternoon, everyone.
Professor Farhad. Let me introduce Professor Farhad. She's an excellent clinician, obstetrician, and a teacher, and always at the forefront of such events. She has organized 2015 New York Fox and is also at present president of Srinagar Obstetrics and Gynecological Society. Professor Farhad, please.
Good afternoon, everyone. The topic theme today is, am I audible?
Yes, ma'am.
Yes.
Okay. The topic is high-risk pregnancy. Obstetrics is perhaps the most difficult area of medical sciences, where every birth is a challenge. And when there are potential risks involved for the expectant mother, the fetus, or the newborn, it would be considered as a high-risk pregnancy. Our institution is one of the largest tertiary care obstetric facility in North India with more than 700 beds. The hospital receives high-risk pregnancies from all corners of Valley, some areas of Jammu and Ladakh as well. The challenge of dealing them is immense and of great importance. The goal is to improve the outcome of the patient's current pregnancy and as well as her risk for complications in her future pregnancies. And for fulfilling this purpose, staff has to be sensitized and trained to recognize and deal with critical and emergent situations resulting from these high-risk groups. So to have an idea about the caseload in our hospital, as Dr. P.C. Mahapatra has told you, he talked about only cesarean sections, but I will give you an overview of what we receive and what we have received in COVID era. It's around 27,496 admissions till date. And out of these, around 10,000 were recorded as high-risk pregnancies. And majority of them, what we saw in this era was severe degree of anemia, maybe lack of antenatal facilities in field. And it was around more than 3,500 patients who were admitted in the hospital with anemia, majority of them with severe degree anemia and needed a lot of blood transfusion. And followed by around 1,500 cases of preeclampsia and 1,000 cases of postpartum hemorrhage, around more than 600 cases of antepartum hemorrhage, and around 350 patients who had come in obstructed labor, handled, and patients with diabetes and other associated medical disorders. And in this era, we had around 82 near misses were salvaged. And up to 30th November, we had 17 maternal deaths were recorded. And when we holding the maternal mortality meets in the department, the major cause of death and major problem which was seen in these patients, a change which we have seen previously, it was anemia or the hemorrhage. This time it was severe degree of preeclampsia with all complications which we have seen in book, we have received in the hospital. And majority of them had severe preeclampsia with hemorrhage, pulmonary hypertension, and intracranial hemorrhage. We have lost 17 lives, and majority of them had preeclampsia, followed by anemia, which was either due to postpartum hemorrhage or it was antepartum hemorrhage. We had one maternal death because of COVID, a mother who had COVID positive, but the death was not because of the complications of COVID. It was because of obstetric complications, whom we received very late, and she was almost in irreversible shock when she reached our hospital. So our center being the large tertiary care facility for obstetric emergencies, and the above data suggests that we receive a sizable high risk load in a very critical state as during transportation from peripheries, a lot of critical period is lost. So our staff and the future obstetricians have to remain updated and technically efficient to follow protocols and increase the salvage of such mothers and their little ones. We also need to identify such pregnancies quite early and deal with them accordingly. And this was the reason why we chose the challenging and exciting topic for our young and upcoming obstetricians. At this juncture, our team would like to register out sincere thanks to Professor P.C. Mahapatra, who is also known as Teacher of Teachers. Hats off to you, sir, who called me one fine morning just 2 weeks before that, and he said that our institution is has been chosen for holding this tutorial from North India. Without thinking for a second, I gave him a nod and activated my team for making preparations to hold this prestigious event. The whole team responded as a code blue call, for which I appreciate all of them. To wind up, I would also like to add that COVID has thrown a new challenge to all of us. It is added to the high risk group with its ever changing and enigmatic behavior. I thank you all once again and hope that this program sets up the ball rolling for many future academic virtual feasts. Thanks for once again. Let us be ready for a wonderful academic feast. Thank you very much, sir.
Now I invite Professor Ashish Mukhopadhyay for the welcome address. I did say, I think November, it is 19th December. I'm very sorry. Maybe COVID times, we have just lost dates and everything because of COVID.
Uh, good afternoon and namaste to
Doctor,
all the pretty faces that I see today on the screen. And this is the 8th program of the Obstetric and Gynecology Teachers Forum of India, initiated by Professor P.C. Mahapatra. We started on 5th of September 2020 on the auspicious day of Teachers' Day celebration at Kolkata. The program was at Guwahati. And then we have come a complete 2 rounds and come to North Zone, Srinagar. Now, this is an unprecedented and noble attempt by our Professor P.C. Mahapatra to, unravel the obstetric mysteries and gynecological miseries of patients and making a bridge through this attempt to the medical education and teaching. And I appreciate this from the core of my heart, as has been done by the teachers all over the country. It was really unknown to me about this marvels, obstetric marvels that the Srinagar Medical College, GMC, Government Medical College Srinagar possesses. I was just today morning, I was talking to Dr. Farhat, and she was telling me what is their obstetric load and their faculty strength, the number of students, etc., etc. We are having a nice chat. But it was unknown to me that particularly in this COVID situation, they're fighting so well against this order of high-risk pregnancy. It is no wonder then that they have chosen the subject of high-risk pregnancy. I know it is going to be the subject of discussion for quite some time to come for the students as well as the practicing obstetricians. Now, what was remarkable was that they have been able to provide this service despite this COVID situation. And our hats off to you, Madam Farhat Javin, and your team, And I have heard that she has involved GMC Jammu also, as well as the other medical colleges in the north zone of India. And I am proudly associated with this program. Now, having said that, what is the basic purpose of this program, as Dr. P.C. Mahapatra will be able to tell you much better than me, is that our next generation of obstetricians and gynecologists, the students, budding gynecologists, will be well equipped not only to face the examination that they are going to have in the next few years of life, but also face the challenges of obstetrics and gynecology in their practicing field as well. So I think this is a very, very noble attempt. And I think that apart from the teaching programs that we held in the past with his blessings, the force programs and the other teaching programs, I'm sure Srinagar is a part of one of those programs. It was a noble attempt from all the teachers, and I wish all the teachers of our country be united together to serve the mission of teaching the students at the same time fulfilling the social responsibilities that we possess. With those few words, I would like to invite Professor P.C. Mahapatra, the father of all these programs, and he has been a keen teacher. I have been observing him for a quite long time, and I am terribly influenced by him. Could I have his slide, please, projected? And Dr. P.C. Mahapatra, I think I'm sure about this, needs no introduction. From Kashmir, Jammu and Kashmir to Kanyakumari, and from Gujarat, Kutch to the Assam, uh, everyone knows him. Everywhere we have seen his footsteps, and more importantly, his impact of teaching and gynecology and obstetric practice, dissemination of knowledge has been there, so everyone knows him. Only for the record's sake, I would like to put it straight some facts for Dr. P.C. Mahapatra. He has been a professor of Department of Obstetrics and Gynecology at SCB Medical College, Cuttack. More importantly, he describes himself as a satisfied soul as a teacher. Now, being a teacher, all of us must understand that this is a very strong statement and a very bold statement to make. Well, I am yet to be satisfied soul as a teacher. Now, I am sure that his quench or thirst of knowledge is no less than ours, even though he has achieved the peak of academic and otherwise success. He has been the president of Oxy in 2011. He is passionately involved on teaching undergraduates and postgraduates in obstetrics and gynecology since 1986. And he is also a postgraduate examiner, not only in Kolkata, Guwahati, Mumbai, Berhampur, but many, many, many others. And he has been a satisfied soul as a teacher, I repeat. But to me, if you ask me to describe P.C. Mahapatra in one word, he is more a philosopher than a doctor or a teacher. So welcome, Dr. P.C. Mahapatra. We would like to hear a few words from you about this noble program. Over to you, Dr. P.C. Mahapatra, please.
Am I audible?
Yes, yes, sir.
Bismillah, Rahmat Rahim. Well, thank you, my favorite dynamic teacher, Professor Ashish Mukhopadhyay, for overestimating me. I still remember and cherish the memories of Force, the launching behind of the Force program, the Foxy review course for examination. It has stimulated all over India in all the medical colleges, both the postgraduates as well as the teachers. It has a great impact way back in 2011. And that reminds me today, when during the corona pandemic time, the question of teaching and the problem arises. Then I started thinking of forming a group. And teaching is a passion for me, and I love teachers and students. And that's why I wanted to have a uniformity and a cohesion between the teachers of all medical colleges in India, from east to west and north to south. When I talked to Mr. Anthony of Sun Pharma, who was doing the Force program, then he told, let us have a survey for that. I gave a mail, and surprisingly, the 278 heads of department of gynecology of medical colleges all over India responded very well. Before that, I asked again my executor, Professor Ashish Mukhopadhyay, what is your idea regarding this? He was really thrilled with this. And I told, I'm an expiry date person. You are the main force who will carry out all these. And thank you, Ashish. Today I'm seeing, after launching this program on the Teachers' Day in September 5th from Guwahati, it has expanded the second round, which is already in for that. And that is because of you. And I trust that you are the main convener and coordinator for which the program is running very well for that. And I salute you for that. Well, today, again, when I talked 15 days back to Farhat, when North Zone came, Srinagar, Jammu and Kashmir is one of the very favorite state of mine. I still remember cherish the memories of 2004 when I was a vice president of Foxy. When we decided at that time, Professor Anklesariya was the president of Foxy. We decided to do the managing committee meeting in Jammu and Kashmir for the first time, because we felt that there's so good people and so good teachers, so good clinicians, they should be involved in all activities in Foxy for that. And that has turned around the situation. Then we came many programs in Srinagar, and 2015 Yuva Foxy was really epic. We enjoyed that program, and at that point has given an opportunity to explore what is Government Medical College Srinagar and what is LD Hospital. And one OT we were operating in gynecology and endoscopy in other cases. And there were the other sides. There are 3 OTs where non-stop cesarean was going on. And that has given me an idea to see that this is one of the obstetric load I've never seen in any medical colleges of that. I was just traveling across the country and seeing the medical colleges, the loads of obstetrics. I found, initially I was thinking that Jodhpur was the main thing. I think large number of deliveries are going on there. It has crossed Srinagar when I find that it has crossed also any medical college, even Jodhpur. And now that the obstetric load, the obstetric emergencies, salute you. I salute all the teachers of the medical colleges, of government medical colleges under the able leadership of the great teacher Farah. Today, it's an auspicious moment for me when this program is going on. When I talk to Farad, every time when I talk to many medical colleges, they say that yes, we will talk with our colleagues and then give a positive or negative thing for that, whether we can go ahead with that. But I appreciate Farad. Without asking, without anything, you tell that yes, we are agreeing for that. That gives a strong commitment for teaching and an interest for that. I again salute you, your department, your colleagues, and the whole all professors involved in this program for that, and teachers of teachers who are there for that. You are so interested that you are doing this program, and particularly today is a very focused program on high-risk pregnancy, because I know the pregnancy and the obstetric load of the LD hospital and the government medical college, you can really do the justice of really conducting this program on a very pertinent subject, which day in and day out you face it. And I think there is no words to express thanks and gratefulness to you people who are doing this program for that. And really, Ashish, you have helped this program to be very successful, the Obstetric Gynaec Teachers Forum of India. I want to have an integration, a fellowship along with the teaching program, and contributing to some part to the postgraduates in the next generation for that, mainly on 2 aspects. The teaching program of today's, I consider that this is mainly of 2 aspects. Not to first is passing the examination, no doubt, examination oriented is one. But the main thing is when I and Ashish talked together, we decided that fundamentals. I think making the fundamentals in obstetric gynaec stronger, starting from the postgraduate period, so that every day they face the examination after passing, and we want to deliver the goods. We want to have a product which is really a product worth, and that gives a satisfaction for the teacher. When our product, our students, and when after the 3 years of examination, when they do and contribute to the society, the product must be excellent for that. That is the main purpose of this program. And from east to west and north to south, this program is going on a zonal basis. And today, I again thank and congratulate Srinagar people. Though we are feeling the virtual scenic beauty of Srinagar, we are feeling only, we are not able to see. I assure you, with Asis, we will again go and conduct a physical meeting in the CME and postgraduate teaching program there and there. So today is a very, very good day for me. Not only you have organized, I was so happy that you have involved the other great teachers like Sudha from Jammu and Shima Hakim from Aligarh. One of the two teachers which I respect for the last so many decades, 1.5 decades, I am in contact with them. I know them, what is the teaching interest they have got it and all that. And really, I must thank Farhat for involving all of the great teachers and teachers of teachers for this program for that. I wish that this program will be very, very memorable event in the teachers as well as students for that also. And I congratulate all the postgraduates that you learn it, really benefited from this webinar today. And 19th December will be a memorable day for all of us, teachers and students. Thank you very much, all of you. And thank you, Asis. You are the best coordinator so that the program is going on and all that. And lastly, Sapan, I don't have a words to express thanks to Sapan and the whole team of Sun Pharma who is participating, who is cooperating with us. Thank you very much.
Thank you so much, sir. It was a pleasant words always. To hear you is always a privilege for any of us in India. Secondly, I would just like to make a pleasant announcement here. Yes, I agree with you that it's a pity that we cannot enjoy the beauty, the geographical beauty and the scenic beauty of Srinagar and Jammu, but we promise that we'll come back to you, Dr. Farhat. Dr. Sudha will come back to you and we will enjoy together the beauty of the nature. That is a promise from us. Secondly, I would like to take this opportunity to announce the next program, and I have already, under the leadership of Dr. P.C. Mohapatra, approved the site of Jodhpur. Jodhpur as the next program, which is on 2nd January 2021. And I would like to see Dr. Jodha from Jodhpur. Is Dr. Jodha here? I have already invited him and I have already sent the speaker's link to him. If Dr. Jodha is there, are you there, Dr. Jodha? Dr. B.S. Jodha, are you there? Okay. This is for the information of all concerned amongst us, that the next program is going to be held at Jodhpur and our coordinator will be Dr. B.S. Jodha and the date will be 2nd January 2021 at 2 p.m. onwards. Thank you, everyone. And we would like to get the ball rolling for the program today. Over to you, the coordinator, please. Dr. Farhat, please take over.
Thank you, Professor P.C. Mahapatra, for such kind words. We are really humbled and honored by your words. We are so honored that you have chosen us for this tutorial. And thank you, Dr. Ashish, for your kind words. I hope we are up to the mark. Now we'll be starting today's academic session with our first lecture. It's on recurrent pregnancy failure by our Professor Masuma Rizvi. And the chairpersons for this session are Professor Farhad Jabin, Professor Rifat Ara. Professor Rifat Ara is head of the Department of Obstetrics and Gynecology, SKIMS Medical College, and Professor Samina Sultana, who is our young, dynamic professor. Over to you, Professor Farhad. I think you are on mute.
Hello. Thank you very much, Dr. Zwana. So our next speaker, let us start our academic event and feast now. Our speaker is Professor Masuma Rizvi, who will deliberate on recurrent pregnancy loss. Dr. Masuma Rizvi is an excellent teacher and academician and always ready to hold such events. You just have to give her a call and she's there for the program. I just told her that you have to deliver a lecture on recurrent pregnancy loss. She couldn't say no. She being busy and having other activities and busy schedule, she immediately nodded and she said, okay, I am for it. And she's an excellent teacher and an academician. I would invite Dr. Professor Said Masuma Rizvi to start her lecture and an academic piece now.
Thank you, Dr. Farad, for your kind words. Assalamu alaikum and a very good afternoon to all the participants from the different parts of the country. Our esteemed Professor Mahapatra Saab, Dr. Ashish, before I take you to the discourse of recurrent pregnancy failures, I would like you to have a visual feast of the tour of our valley. Since you people could not come and you are in love with our valley, this is what I would like you to see before I take up the topic, which is too challenging for both the patient as well as the
Sorry, we are unable to see.
not unable to see. You are not able to see.
No, kindly share it. So you
I
can.
have shared the screen.
No.
Audio is seen, but audio is, we can hear it, but we cannot see.
Just a second.
So kindly minimize and open your Zoom window.
Just
Moshuma, that's really a great idea. Great idea.
thank you, sir.
Share screen button. Then you have to select a computer sound and screen sharing video clip. No, madam, not yet shared. I'll tell you, madam, simple steps. Go to Zoom meeting window. You can see share screen on center bottom. Just click on it.
Just a second. I need help for this.
Yeah, definitely.
Uh,
Open Zoom window. Kindly open Zoom window.
yes,
Yeah, you can see center bottom share screen, green icon.
I shared the screen with you.
No. So click on it. Just green icon, share screen. Click on it.
Are you able to see it?
No, madam. What you can see in front of this screen?
I can see the presentation in front of me.
No, kindly minimize it.
I have minimized it.
Open Zoom window, Zoom meeting window.
I again opened the Zoom window.
You can see center, bottom center share screen and a green icon.
Just a second. I'll stop the video for some time and
You have stopped the video, no? Okay. Now it's loading. Yeah, now you can open the video. Also, one more thing, before that, you have to you have to select some options for computer sound. Anyway.
Excellent. Now we can see. Thank you, Moshuma, for your innovative idea.
thank you, sir.
She is innovative. I described her.
I hope you liked it, but there were some technical hitches which I could not fix.
No problem.
Now going to recurrent pregnancy loss. As you all of know, you know that motherhood, though challenging, is divine. It seems to be the most powerful equation governing life. the most complex, mystical, mythological, and yet the most logical and powerful status is motherhood. Patriarchal society failed pregnancy as failed motherhood. Repeated failures with traditional psychological mindsets add to the saga. The question is, how do you diagnose recurrent pregnancy loss? The recurrent pregnancy loss is always a retrospective diagnosis, and it has been debated over and over by international committees. What should be the basis? 2 losses or 3 losses? Currently, 2 or more pregnancy losses before the age of viability have been considered as recurrent pregnancy loss and have been accepted both by ASHRAE and ASRM. The losses can be primary, secondary, or tertiary, depending upon whether or not the couple has been able to achieve a viable pregnancy or not, and tertiary, whether it's interspersed with live pregnancies in between. Whether the losses should be consecutive and non-consecutive, again, is a matter of debate, and currently consecutive losses are being considered as recurrent pregnancy losses. Taking the prevalence of recurrent pregnancy loss, as you all know, spontaneous abortion rates is loss of pregnancies is as high as 50% if we take biochemical pregnancies also into account. Early pregnancy loss is a common complication, and in different registries, it is from 15 to 30%. Now, 13.5% if we take the population-based register study. Recurrent pregnancy loss is less prevalent, and if you take losses prior to 20 weeks, it is 1 to 2%. When more than 3 losses are taken into account. If 2, then the clinical pregnancies are taken into account, 0.8 to 1.4%. Biochemical pregnancy, if taken into consideration, it is 2.3%. Now, exact prevalence, again, is a difficulty, as the number of women who record recurrent pregnancy loss, the numerator is elusive, and so is the denominator when you take into account whether it is all fertile women who you take into account or women who are trying to get pregnant. Now, the psychological and the social impact of RPL is tremendous. It's a negative life event, and repetitive nature intensifies grief. Men, the emotional impact is underrated, although it's immense. The society always has a negative role in for females who are facing recurrent pregnancy loss. Once you are organizing care for women with recurrent pregnancy loss, you need to take into account their psychosocial setups. If you go for the etiology of recurrent pregnancy loss, again, 40 to 50% is elusive, unexplained. Genetic factors contributing to 2 to 5%, thrombophilias, both acquired and inherited, 10%, metabolic and endocrine disorders, 17 to 20%, anatomical, 10 to 15%, and male factors, the percentage still under research. When you talk of etiology, the genetic factors could be embryonic, inherent, or they could be transmitted through the parent. Now, embryonic could be chromosomal imbalance, as you see that early first trimester abortions generally are anembryonic, and other genetic defects which could be inherent to the embryo itself, and the genetic defects which would be inherited from the parents could be balanced reciprocal rearrangements, Robertsonian translocations, chromosomal inversions, and chromosomal deletions. Now, anatomic factors could be congenital and acquired. Congenital would be the Mullerian agenesis or incomplete fusion, septum resorptions, then abnormalities because of diethylstilbestrol exposure, uterine artery anomalies, cervical incompetence, and acquired cervical incompetence because of instrumentation, difficult deliveries, handling, then synecdoche formation, the uteri leiomyomas, and the adenomyosis. The thrombotic factors would be hereditary thrombophilias, which could be acquired thrombophilias, which is the antiphospholipid syndrome, the most prevalent and most amenable to treatment. Then endocrine factors, the most prevalent is the thyroid disorder, and again amenable to treatment, diabetes, prolactin disorders, luteal phase insufficiency, and PCOS. Now, infectious factors have also been attributed to play a minimal role in recurrent pregnancy loss, as has been seen in endometrial sampling of patients with recurrent pregnancy loss. And again, the outcome is improved once they are treated. Then a lot of importance is being given to currently the immunological factors and the unexplained pregnancy loss which are seen. Now, there is a cellular mechanism, so there is a delicate balance of the hormones, the coagulation, and the immune system, which acts at the feto-maternal interface and allows this pregnancy recognition as self. Many theories have been postulated, and the mechanisms by which the pregnancies are lost have been attributed to the different expression of HLAs, A, B, C, and G, alteration in the cellular immune regulation, then the T helper cell immune responses, which is an imbalance between Th1 and Th2, whereby tipping the balance towards Th2, then cytokines, which are released at the decidual and at the feto-maternal interface, and the growth factor deficiencies. Then hormonal alterations and tryptophan metabolism have also been added to the list. Then the antibody formations, again, thyroid, antisperm antibodies, antitrophoblast antibodies, and blocking antibody deficiencies have also been implicated. The other factors which have been attributed are altered uterine receptivity, which could be because of the imbalance of the immune coagulation as well as the these metabolic disorders, then environmental with toxin, drugs, cigarettes, and caffeine playing a role, maternal medical illnesses, male factors, exercise, excessive exercise, and stress. Now, what is the aim? Why do we want to have a retrospective diagnosis of these patients? Our aim is to help the couple achieve a healthy pregnancy. And in organizing the care for recurrent pregnancy loss couple, we need a dedicated RPL clinic, which needs to be away from the antenatal clinic as well as from your maternity homes. Now, before the evaluation needs to occur prior to embarking on the new pregnancy. The main aim is that you need to gain as much information as possible from the couple so that you frame your management accordingly. As you see that in any, whenever you see a patient, 80% of your diagnosis is from the history only. So it forms the basic, it is the basic for achieving a successful pregnancy again in these patients. So whatever history you can, the previous losses, any live births, and their obstetric history, their menstrual history, their menarche, all these have a relevance in evaluating and framing up the evaluation and the treatment protocol of these patients. A thorough examination and accordingly subsequent relevant investigations done. Now the aim is to educate and re-educate the couple again regarding the myths and the misconceptions they have regarding the causes and their future prognosis. Then again, appropriate evaluation and planning is to be done in these patients. And every case, the treatment has to be tailor-made and your psychological needs have to be taken care of. Now, once you formulate the treatment plan, 50% of the times you still might not be knowing what the cause is. So there's a lot of scope for research in these patients. Now, apart from the known etiological factors, there are certain risk factors for recurrent pregnancy loss. Age being one of the factors, both male and female age are important. Best pregnancy outcomes are seen in women who are between 20 and 25 years of age. Advanced maternal age, is a well-established factor for subfertility, fetal anomalies, stillbirths, and obstetrical complications. And there is a strong association between female age and recurrent pregnancy loss. So women will sensitively need to be informed who are seeking pregnancy that the risk of pregnancy loss rapidly increases after the age of 40. So again, an opener that interventions should be done earlier. Male age above 40 again has been implicated to have faulty sperms and still under research. Another risk factor, stress. There is no direct evidence that stress is associated with RPL, but studies do indicate an association. It again needs prospective studies in assessing the impact. Now, occupational and environmental exposures like heavy metals, pesticides, anesthetic agent exposure are associated with risk of pregnancy loss. Now, chronic endometritis again is considered a risk factor, as has been seen that the histopathological studies have shown that women with recurrent pregnancy loss, 7 to 58% of the times they have chronic endometritis. And we believe that since treatment has improved the rate of live births, this should be kept in consideration. However, more RCTs and prospective observational studies are required. Now, faulty endometrial decidualization. The endometrial cells, they act as a checkpoint for embryo quality implantation for normal embryos. Abnormal decidualization, it renders the endometrium excessively permissible to implantation, but unable to sustain the pregnancy. So this, again, needs to be kept in mind. Now, certain health behavior modifications, which are easy and are beneficial in improving the pregnancy outcome in patients, cessation of smoking, achieving a healthy BMI, reducing the caffeine intake, improving their physical and mental health, reducing the alcohol consumption, and certain lifestyle changes like avoiding intercourse during early pregnancy, stopping soft drugs like cannabis, and high dose radiation during pregnancy to be avoided. The importance of detailed history, as I said previously, can never be undermined, as your diagnostic makeup will be tailored on those points. ASHRAE recommends to base prognosis also on the number of previous pregnancy loss and the age of the patient. When you come to screening, every patient, you do not give an array of investigations to every patient. So screening for genetic factors where there are risks, where you have an embryonically, where this genetic analysis of pregnancy tissue has been done. It is seen that if there is an abnormality, the recurrence rate is 30 to 57%. So the tests are conditional, array CGS is recommended, and gene sequencing will be the future, whereby all abnormalities, even microdeletions, repetitions, and translocations can be picked up. Now, parental genetic analysis is again seen in 2 to 5% of the couples with RPL, and balanced structural chromosomal anomalies, reciprocal Robertsonian translocation, deletions and repetitions are seen. Testing again is conditional depending upon the risk factor assessment of the patients. Then thrombophilia screening. Hereditary thrombophilia screening, see that the prevalence of hereditary as a cause of RPL again is unclear. The various factors, factor V latent mutation, prothrombin mutation, CES, antithrombin deficiency, MTHR mutation, all are not seen to give rise to recurrent pregnancy loss. Testing is recommended in women who have had an experience of previous venothrombic embolisms, or in whom there is a family history, or women who have additional risk factors for thrombophilia or research purposes. Now, acquired thrombophilia, this is the most common, which is amenable to treatment, and a screening is recommended by all societies. Lupus anticoagulant, ACA, IgG, IgM, beta-2 glycoprotein antibodies, strongly recommended in women for after 2 pregnancy losses. Now, immunological screening is gaining a lot of importance these days, as we still are elusive of the 50% of recurrent pregnancy loss in finding the cause. You see that there is a delicate balance of HLA expression at the feto-maternal interface, the expression of HLA1, A and B, then which is blunted in these patients, then C and G produced more in these patients. However, it is not routinely recommended unless you are considering Scandinavian women who with secondary RPL where the firstborn is a boy. Now, anti-HY antibody detection in serum, again, it has a very negative prognostic impact if found, but routine testing not indicated. Then cytokines, different kind of cytokines which are expressed in different quantities, and there is a interplay of these cytokines which are secreted at the level differently. But the commonest which is measured is TNF alpha, and it is found higher in RPL women, but again, not recommended as a routine testing. Same is true for cytokine gene polymorphism. Anti-nuclear antibodies testing considered for explanatory purposes. Natural killer cells, again, in peripheral blood as well as in decidual tissue. Again, routine testing, there is insufficient evidence, but they do definitely play a role in accepting and rejecting a pregnancy. Other immunological tests is anti-HLA antibodies, celiac disease serum markers, anti-sperm antibodies, but routine testing for all is not recommended, and except for research purposes. Then we have the metabolic and the endocrinological screening. Thyroid screening is universal and should be done, both TSH, anti-TPO, T4 levels. So based on high prevalence, we see that subclinical hypothyroidism and thyroid autoimmunity in women with RPL, and potential for treatment and healthy pregnancy outcome, this screening is recommended by all. Abnormal TSH and TPO activity levels should be followed with T4 levels. Now, PCO and disturbance of insulin metabolism, not routinely, only in select cases who do have history of PCOS or hyperinsulinemia or hyperandrogenemia. Then prolactin abnormalities, in absence of clinical symptoms of hyperprolactinemia, testing not recommended. Association of RPL is inconsistent in prolactin abnormalities, although it is recommended where you have features of hyperprolactinemia. Now, luteal phase deficiency in patients with luteal phase deficiency, stress and obesity and PCOS, it is recommended. Now, do we routinely have to do ovarian reserve testing in this? No, only in patients with advanced maternal age, as the ovum of these women might be faulty. Not routinely recommended, but if you have signs of premature ovarian failure, and you can do it to estimate the future chance of live pregnancies in the couple. Then luteal phase insufficiency, again, there is an inconsistent association between RPL. Then androgen testing, again, routinely not recommended. Vitamin D, a lot of studies have come up where there is seen a possible association with vitamin D deficiency and recurrent pregnancy loss, and supplementation improves the outcome. Now, elevated LH and hyperhomocystinemia is inconsistently associated, and only in patients who have features, it is to be recommended. Now, anatomical investigation is a must. You know that congenital malformations in the form of Mullerian tract malformations, very easy to pick up with a 3D ultrasound. So the multiple defects which are seen, which are associated with RPL, unicornuate, bicornuate, normal cervix, but bicorporate with double cervix, the prevalence with congenital malformations and RPL is 13.3% as against 5.5% in general population. Then cervical weakness, which is congenital, again, it is a clinical diagnosis and recognized as second trimester, repeated second trimester loss, and need to be followed. Then acquired uterine malformations in the form of submucous myomas, endometrial polyps, uterine adhesions are prevalent, and the clinical relevance is unclear, as there are two schools of thought whether removal or continuation will exactly improve the pregnancy outcome. Now, but all anatomical investigations are easy to assess, and preferred mode would be a transvaginal 3D USG, sonohistogram for more accurate, which is more accurate than HSG, and even can check the tubal status. So high-end investigations are not recommended. MRI as first-line option for uterine malformations not recommended, only if you do not have the facility of 3D USG. Since there are a lot of surgical trials for septate uterus which have been given and have been followed with successful pregnancy outcomes, so it is worth doing. Now, male factors, do they really contribute to RPL? Yes, DNA damage by oxidative stress has been seen, and DNA fragmentation again is being proposed as a cause of RPL now. So, and in addition to that, lifestyle factors like smoking, alcohol consumption, exercise pattern, and body weight in males does have an effect on the sperm quality. Now, how do you assess the prognosis of a couple with RPL? Prognosis strongly depends upon the number of previous pregnancy losses in maternal age. In maternal ages between 12 and 19 years, it's 13%. It's 11% in 20 to 24 years, 12 in 25, 29. And you see it is highest, that's not for 95% in poor prognosis in women above 45 years of age. The prognosis is again not good where the couple maternal age is 35 years and above and the paternal is 40 and above. Now, how do you treat? Treatment of RPL with genetic background. All couples with results of an abnormal fetal or parental karyotyping, they need genetic counseling. And they should be informed about possible treatment options available, including their advantages and disadvantages, including IVF pregnancies, then prenatal genetic testing, donor sperms, and even donor eggs if the fault lies on the female side. Now, the testing is array CGS and next generation sequencing has been recommended when pre-implantation genetic testing for unexplained pregnancy loss is being done. PGT for RPL with genetic background, PGT-M and G, these couples with high risk of transmitting gene disorders such as monogenic disease or structural chromosomal anomalies need to be counseled regarding their future pregnancies with normal intercourse. Now, treatment of RPL with thrombophilia. For hereditary thrombophilia with history of RPL, antithrombotic prophylaxis is to be given only for prevention of VT or for research. Outcome is for a routine prophylaxis without a thrombotic event has not been seen to improve the live childbirth. However, with antiphospholipid syndrome, aspirin 75 to 100 milligrams per day started before conception, and prophylactic dose of heparin, which is unfractioned or low molecular weight heparin, starting on positive pregnancy test is strongly recommended by all associations. And the doses 40 to 80 of low molecular weight heparin, low molecular weight being superior as it doesn't need much monitoring. And steroids, giving of steroids in such patients, again, some do give, but the benefit, no, not much benefit. Now, IV immunoglobulins have been seen to be, which decreases the lupus activity, however, needs more research. Now, with in treatment where you have immunological background, as such, we do not have many immunological biomarkers except high titers of APA antibodies, which can be used for selecting couples with RPL for specific treatment. The specific treatments are immune stimulating therapies like leukocyte, lymphocyte immunization, immunosuppressive therapies, which is IV immunoglobulins, progesterones, and interlipid infusions. All are being used, but not recommended for, these are under research. TNF alpha inhibition with blocking antibodies, adulamab, inhibitory recombinant proteins are being tried. Now, metabolic or endocrinological abnormalities, as you know, that thyroid disorders, they are 100% treatable, should be treated preconceptionally. In SCH, conflicting evidence about risk-benefit ratio, but better to treat. Different societies have come with a different the cutoff levels for TSH, and currently adopted is 2.5 in pregnancy. Now, women with SCH and RPL pregnant check TSH levels at earlier age and treat thyroid. In autoimmunity, pregnancy positive, check TSH and treat if hypothyroid. Euthyroid with antithyroid antibodies and RPL, again, some say treat, some say don't treat, but the Endocrinological Society says should be treated, and balance tipped towards treatment. Now, other The role of progesterone and HSG in luteal phase deficiencies is again controversial, not routinely, but the outcomes in different studies have shown have a positive note. Metformin and insulin being used in controlling diabetes, and again control of diabetes if it is type 2 diabetes prior to conception, so that patients are euglycemic on embarking pregnancy. Now, bromkriptine in hyperprolactinemias has been beneficial. Vitamin D is widely being used, as particularly in our part of the world where vitamin D, women are vitamin deficient due to their lifestyles. Now, uterine abnormalities. There's no strong recommendation for materioplasties in bicorporeal uterus with normal cervix or hemiuterus, as correction surgeries are extensive, time-consuming, expensive, and do not leave behind much of functional endometrium for implantation. Insufficient and have not been implicated in recurrent losses, as patients with uterine diadelphys have had multiple successful pregnancies. Insufficient evidence for treatment of bicorporeal uterus with double cervix too. Now, but the septal resection, more promising is the hysteroscopic resection in septate uterus, as the live birth rates have improved with these management and needs more prospective study. Removal of intramural fibroids and submucous fibroids as well as endometrial polyps. Again, there are conditional recommendations, but personally I believe that they do hamper the implantation and should be removed. Now, hysteroscopic adenolysis, again, there is a risk of recurrence and is being treated with non-surgical management, which is stem cell therapy. Now, patients with cervical weakness should be offered serial sonographic surveillance, and cerclage should be considered. Now, when you come to the male factor, do they need treatment? At least the smoking, alcohol consumption, obesity, and excessive exercise, which are having a negative impact, they are modifiable risk factors and can be done. Now, sperm selection is not recommended unless it is an IVF pregnancy. Antioxidants for men, as we see that oxidative stresses are more in these patients, have not showed improved live birth chances, but can be given a trial. Then unexplained RPL is a zone which is a gray zone, and many therapies are being tried. Lymphocyte immunization therapy, though it has more adverse effects for both the fetus and the mother than benefits. Intravenous immunoglobulins, which are suppressing the immune response of the females, is being given. Prednisolone, not routinely recommended. Then anticoagulation, the best anticoagulation is to be given is in women who are APLA positive, and using empirically aspirin and enoxaparins has become a norm. Now, folic acid to be started preconceptionally routinely. Vaginal progesterone, again a controversial role, although it is believed to have suppressed the immune response at the endometrial level and allow implantation. Then granulocyte colony stimulating factor, again insufficient evidence. Now, endometrial scratching prior to IVF and ICSI cycle had gained widespread usage, but it has been challenged strongly. Non-conventional treatments for RPL, Chinese herbal treatment, acupuncture, IVF ICSI combined with PGS, particularly where there are genetic defects, then diet and antioxidants, and homeopathy is all being tried. Now, prognosis all depends on the underlying cause, number of previous losses, age of the couple. Many pre and post-conceptional tests proposed to predict pregnancy outcome have come, but none is substantiated or standardized. The documentation of cardiac activity on USG is the lone test which can be utilized for prognostic value. Now, the take-home message for couple with recurrent pregnancy losses: never lose hope. Tender love, care, prayers, and evidence-based medical management can be the trick. The chance of viable birth, even after 4 prior losses, may be as high as 60%. There is 20 to 80% successful pregnancy prognosis with cytogenetic etiology, 60 to 90% in corrected anatomical anomalies, 90% in corrected endocrine abnormalities, and 70 to 90% in patients receiving therapy for antiphospholipid syndrome. So the hope is the only thing which sails us through. Thank you very much.
Thank you very much, Dr. Masuma. It was a wonderful and elaborative this talk on recurrent pregnancy loss, a challenge for all obstetricians. And majority of the times we are always in dilemma what to do, especially in patients where there is unexplained infertility. Unexplained recurrent pregnancy loss. These are the patients who have almost what your slide also showed, that 40 to 50% patients have unexplained cause for recurrent pregnancy loss. Thank you very much. Thank you very much once again. Question and answer session will be once we complete our program. That will be last of all. Thank you once again.
So thank you, Masuma, Dr. Masuma, for a nice presentation, excellent, and I'm sure the PGs will be benefited by this. And thank you, chairpersons, Professor Farhat, Professor Rifat, and Professor Samina. Now we come to our next session, and the next session is on diabetes and pregnancy, and it is with a twist, Kashmir perspective. The speaker is our young, efficient, and dynamic Professor Samia Mufti. And the chairpersons for this session are Professor Abida Ahmed. She's head of the department Obstetrics and Gynecology, Institute of Medical Sciences, SORA. She is a highly efficient and acclaimed teacher as well. Our next chairperson is Professor Nighat Firdaus, a highly admired obstetrician for department and always at the forefront for such academic events. And our third chairperson is Professor Tabassum Parvez, but I'm sure she had some problem. Will be the chairpersons for this session, and over to Dr. Nighat.
Assalamu alaikum. Am I audible?
Yes, yes, you are audible. You're audible, slides are visible.
Okay.
Samia, all the best.
Thank you, sir. Assalamu alaikum and a very good afternoon to everybody. Before starting, I would like to thank Professor P.C. Mahapatra, Dr. Ashish for giving us this wonderful opportunity for learning and sharing ideas. And I would definitely like to extend my thanks to our HOD, esteemed HOD, Professor Farhat Jabeel, Professor Rizwana, for providing us with such an academic feast, even in the times of COVID and difficult times. I'll be talking mainly on GDM, and then I'll share some information regarding the GDM scenario in Kashmir. Diabetes is the most common medical complication of pregnancy. Worldwide, the prevalence of type 2 diabetes mellitus and GDM is increasing. So we'll come across more and more of diabetic pregnant ladies in our clinical, day-to-day clinical practice. This, as you can see, is the graph of the prevalence of diabetes in USA from 1995 to 2015. This is the prevalence of diabetes in various cities of India. You can say in some, the red is for men and the blue bars are for the women. The overall prevalence you can see is more in women. So we will definitely, the overall prevalence in India is higher than in the West. And it has been throughout the country, it is ranging from 10 to 14%. In non-pregnant ladies, the type of diabetes, as we all know, is based on its presumed etiopathology and its pathogenesis, and it can be either type 1 diabetes. It can be either so it can be either because of absolute insulin deficiency, which is the type 1 diabetes mellitus, and it can be because of the insulin resistance. It can be because of the इसमें मेरे को वीडियो नहीं आ रहा.
Samya madam,
Just a
Samya madam,
second. Yes.
Samya madam and Nigat madam. So you are nearby. So kindly, like if you can move somewhere, one person, so we'll avoid background noise.
Sorry, there was some problem with the video, so we are getting the video now. So,
No, Nigat madam is nearby you, ma'am.
yes, Nikat ma'am is nearby.
Yeah, that's why we are getting echo. There is a lot of
And
disturbance.
Samina is nearby. Samina, thoda kuch jauh. Is it okay now? Is it
Better,
okay?
but still we are getting. Still it is there. Still echo sound is there.
Echo is there? What do we?
Others have to mute. Let others mute.
No, if later others mute also, speaker side will get echo, madam.
Mute everybody mute the. It is
No, if it is muted also, you will get from your side.
So if I take out my earphones, will it be okay? Is it okay like this? What about the echo now?
Now it's better, but still coming. Okay, go ahead.
Okay. So in non-pregnant ladies, we know that diabetes is classified on this basic etiopathogenesis and pathophysiology. It can be because of absolute insulin deficiency as type 1 diabetes mellitus, or it can be because of insulin resistance or relative insulin deficiency known as type 2 diabetes mellitus. So the previous terminology of insulin dependent and non-insulin dependent diabetes is now obsolete. In pregnancy, diabetes can be classified as pre-gestational. So that is women who are already having diabetes, which can be either type 1 or type 2. And then it can be gestational diabetes, which accounts for the maximum number of diabetic cases in pregnant ladies. So gestational diabetes is defined as any degree of glucose tolerance that either commences or is first diagnosed in pregnancy. This definition holds whether or not you are using insulin for the treatment, and it undoubtedly includes all those ladies who have not been previously diagnosed, who were unrecognized before pregnancy, so all those ladies of type 2 diabetes mellitus who were unrecognized before pregnancy. So when the incidence of GDM and diabetes in pregnancy is increasing globally in tandem with global rise in obesity and type 2 diabetes mellitus, and when considering the high percentage of of a large chunk of population who are unrecognized, so we can definitely say that many of these ladies who are diagnosed as GDM might actually be previously unrecognized type 2 diabetes mellitus patients. It affects 2 to 10% of all pregnancies in USA, and in India, the estimated prevalence is 10 to 14.3%, which is much higher than the West. And according to most recent International Diabetes Federation 2017, GDM affects 17% of all pregnancies worldwide. Of all the diabetic patients that we come across in pregnancy, GDM will account for 90% of all these cases, and type 2 diabetes mellitus comes next, which accounts for 8% of cases. Then there can be other causes of hyperglycemia, which will include type 1 and as well as other endocrinological causes. So being similar to type 2 diabetes mellitus, GDM can be considered to be a window to reveal a predisposition to type 2 diabetes mellitus. A previous diagnosis of gestational diabetes carries a lifetime risk of progression to type 2 diabetes of up to 60%. We're all aware of exaggerated physiological responses, physiological changes that occur in glucose metabolism in pregnancy. Normal pregnancy is characterized by mild fasting hypoglycemia, then postprandial hyperglycemia and hyperinsulinemia. And ingestion of glucose will evoke certain unique responses in pregnancy, like persistent prolonged hyperglycemia, hyperinsulinemia, and then suppression of greater suppression of glucagon. These responses are not because of the changes in the metabolism of insulin, because the half-life of insulin in pregnancy remains the same as in pre-pregnant state. But it is mainly because of the pregnancy-induced insulin resistance, to ensure that a steady level of this glucose is supplied to the fetus. A steady supply of glucose is available for the fetus in the postprandial state. The resistance mainly stems from the placental secretions of various diabetogenic hormones like placenta-derived growth hormone, placenta-derived cortisol-releasing hormone, which stimulates the maternal adrenals to secrete more of cortisol, human placental lactogen, progesterone, prolactin, and then some hormones derived from the peripheral adipose tissue like leptin, and also certain inflammatory factors have been found responsible for this, like tumor necrosis factor and cytokine. But why GDM? Why don't then all the pregnant ladies develop GDM? It is because in these ladies, the ladies who develop GDM, it is not only because of the peripheral resistance, it is the beta cell dysfunction on a background of chronic insulin resistance. The beta cell response to the glucose ingestion is altered in these ladies. And at a molecular level, we can say it is a defect in the insulin signaling. Like there is defective insulin receptor phosphorylation, there is defective expression of insulin-related substrate, a decrease in the glucose transporter 4, which is the primary transporter of glucose into the cell. So at molecular levels, it could be because of the defective insulin. This is where genetic predisposition comes into play. So epidemiologically, studies of risk factors for GDM are limited and confounding. But despite all these concerns, certain factors have been found to consistently raise the risk of developing a GDM. And these include body mass index for more than 30 kg per meter square, excessive weight gain during pregnancy, previous gestational diabetes, of course, family history of diabetes, and family origin from ethnic groups of with high prevalence rate. It has been seen that if an Indian goes to America and they live in America even for generations, they still have a higher chance of developing GDM than their Western counterparts. So specifically, women from the country or with the country of origin, India, Pakistan, or Bangladesh, Black Caribbean, and Middle East. Other risk factors include previous history of bad obstetric outcome, previous history of having a born macrosomic baby, polycystic ovarian syndrome, and evidence of increased insulin resistance like acanthosis, severe obesity. So this is simply a table showing the risk factors, the statistics of which risk factors are more strong in predisposing to GDM. So as we can see, a history of GDM in previous pregnancy definitely has the highest, carries the highest risk of developing GDM in this pregnancy as well. The odds ratio is here 13.2, and the other risk factors you can very well see in this. The body mass index plays the next important role, the odds ratio being 3.2. GDM is associated with a number of maternal and fetal complications. Adverse consequences of GDM seem to be different from that in pre-gestational diabetes. It has been seen, especially with regards to the congenital malformations, it has been seen that the ladies with GDM have just a marginally increased risk of developing this congenital malformations in the fetus. In a large study which was done in Sweden in 2010, it was seen that these ladies, the GDM, the patients of GDM had 2.3% chances of delivering a congenitally malformed baby as compared to the normal population, 1.8 in the normal population. This is in contrast with the overt diabetes or pre-gestational diabetes, where the risk of developing malformations is much higher. However, the other similar to overt diabetes and pre-gestational diabetes, the risk of preeclampsia is definitely increased in GDM. The risk of increased cesarean delivery, risk of shoulder dystocia is similarly increased in GDM as well. Of the fetal complications, macrosomia is very important. We all know the insulin-like growth factors are what are involved in these, play a major role in developing macrosomia, and we'll not go into those details. What is of more concern to us is that this macrosomia can lead to shoulder dystocia and brachial plexus injuries. In a Chinese study, over 80,000 normal vaginal deliveries that they did, they found that if the baby birth weight was 4.5 kg or more, the chances of developing shoulder dystocia were 76-fold increase. That is the way that is very high incidence. Another this important of this fetal complication or neonatal complication, which is of grave concern, is neonatal hypoglycemia. This is basically triggered by hyperinsulinemia, and it starts as soon as we clamp the cord, and the chances of developing some babies can develop very serious hypoglycemia, which is defined as blood sugar levels less than 35 milligram percent within first few minutes of the birth. And this risk is 50% in macrosomic baby, but even in those ladies whose this GDM is under control, the blood sugar levels are much under control, the risk of developing this neonatal hypoglycemia is 5 to 15%, which is quite high. And 3/4 of these cases usually occur within first 6 hours of delivery. Despite almost 50 years of research, a consensus regarding the optimal GDM screening has still not been reached. ADA and ACOG recommend screening of all pregnant ladies with no high risk factor at 24 to 28 weeks and with risk factors at first antenatal visit. WHO and FIGO also endorse the same universal screening for GDM between 24 to 28 weeks. We can do a single step screening, that is 75 grams of oral glucose test. Women are given 75 grams of anhydrous glucose, that is equivalent to 2.5 grams of glucose monohydrate in a glass of water after 8 hours of fasting, and blood glucose levels at fasting 1 hour and 2 hours are obtained. In a two-step test, the glucose challenge test is first given with 50 grams of glucose irrespective of the fasting status of the woman. The blood glucose levels are then measured 1 hour later, and the cutoff is 140 milligram. Anything above that is abnormal. And then these ladies can be subjected to a step 2, which is a 100 grams oral glucose tolerance test. The prerequisites for OGTT are that minimum fasting should be 8 hours, maximum 14. She should be fasting for 8 to 14 hours. For the previous 3 days, she should be having unrestricted diet, no restriction on this carbohydrate intake. At least 150 grams of carbohydrate she should have been taking. And patient must be seated throughout the test, and she should not smoke. So then the GDM is diagnosed as per the various criteria, Kusten and Carpenter criteria. We all know 1982, they gave these criteria: fasting 95 milligram per deciliter, 1 hour 180, 2 hour 155, and 3 hour 140. If any two values are met or exceeded, the lady is diagnosed as GDM. The latest criteria that we use that are internationally more in use are IADPSG criteria, International Association of Diabetes and Pregnancy Study Groups, where the criteria are fasting 92, 1 hour should be less than 180, and 2 hours should be less than 153. If any one criteria is met, the lady is diagnosed as GDM. We also have a diabetes in pregnancy study group of India. They have proposed a OGTT with 75 grams of glucose, a single step. 75 grams of glucose are given irrespective of the fasting status, and then a 2 hour value is obtained. The value of more than or equal to 140 is considered as diagnostic of gestational diabetes. However, the sensitivity of this test is low. AOCG still support the two-step approach for diagnosis of gestational diabetes, and in India, we recommend the screening, universal screening at the first visit with simple fasting blood glucose levels, and then OGTT at 24 to 28 weeks. This is the algorithm. The lady comes for the first booking in the first trimester. If we go for fasting blood glucose level, fasting less than 92 milligram deciliter means she is non-GDM. 92 to 125 means she is GDM, and more than 126 or HbA1c of more than 6.5 means over diabetes. And then in non-GDM ladies, we further go for single-step OGTT at in a fasting state at 24 to 28 weeks, and then we use the IAD-PSG criteria for diagnosing GDM. If in the low risk patients, this will suffice, but in high risk cases, we need to go for a repeat GTT at 32 weeks. So the management, early initiation of therapy is very important in pregnancy. Hartling and colleagues, in a large study, they concluded that early initiation of therapy definitely significantly lowers the risk of various complications, lowers the risk of developing preeclampsia, lowers the risk of macrosomia and shoulder distortion, other complications. The goals of the treatment the goals are that fasting blood sugar should be less than 95, 1 hour less than 140, and 2 hour less than 120. And the fetal ultrasound parameters are also used to modify the treatment, especially the abdominal circumference. If the abdominal circumference is more than 75 percentile, the fasting should be less than 80 and 1 hour should be less than 100. And if the abdominal circumference is less than 75 percentile, fasting should be less than 95 and 1 hour should be less than 140. So medical nutritional therapy, this can be the primary therapy in 30 to 90% of GDM cases. Every GDM case does not need a pharmacological therapy. The goals are we have to choose healthy, low carbohydrate, high fiber sources of nutrition, and with fresh vegetables as preferred carbohydrate sources. Then we have to count the carbohydrates and adjust the intake as per our blood glucose measurements. Avoid sugars, simple carbohydrates, and highly processed food. We have to avoid dairy and juices, and most of the fruits have to be avoided. We have to eat small, frequent meals so as to reduce the risk of postprandial hyperglycemia and preprandial starvation. The major components of this, which have to be considered in medical nutritional therapy, is the caloric intake, which is based on the BMI of the patient and the amount of carbohydrates that you are taken, and then the distribution of the calories over the day. If the BMI is less than 25, then our goal is to achieve the weight gain of 11.4 to 15.9 kg. So the caloric intake has to be 30 kilocal per kg per day. If the BMI is between 25 to 30, 6.8 to 11.4 kg is our goal for weight gain, and 25 kilocal per kg per day should be the caloric intake. If the BMI is more than 30, then up to 7 kg of weight gain is sufficient, and the total caloric intake should vary from 1250 to less than 2500 kilocal per day. Of the total calories that we are taking, carbohydrates should comprise only 45% of the diet, 30% should be protein, and 25% should be fat, mainly the unsaturated fats. And these calories are distributed into 3 major and 3 minor meals. 3 minor meals like snacks, and if the BMI is more than 30, you can skip the snacks, the minor meals. Programs of moderate physical exercise have been shown to lower the maternal glucose. 30 minutes of mild to moderate exercise can drop the blood glucose level by so 23 milligram per cent. Although the impact of exercise on the neonatal complications is still awaits certain rigorous trials, but overall the benefit of exercise has been established in diabetes. Light exercise in the form of brisk walking, especially after meals, is recommended. It improves the insulin sensitivity as well as, and that is how it decreases the blood glucose levels. And then in the major component, the main component of this treatment in this diabetes GDM is that blood glucose monitoring should be done regularly. Self-monitoring of blood glucose is very important, and it is more superior to the intermittent office monitoring. And these reports should be recorded. We should educate the patient to record the blood glucose levels, which will give us an idea over the time how her blood glucose levels are behaving. HbA1c is also a helpful ancillary test, and it can be checked at 4 weeks of 4 weeks interval. Now, when we need the pharmacotherapy, insulin is the preferred first-line agent. For persistent hyperglycemia, when this blood glucose levels are not being controlled by diet and exercise alone, and if we have to start the therapy if fetal abdominal circumference at 29 to 33 weeks is more than 75%. So insulin is preferred because it does not cross the it is helps in tight glucose control. It can achieve the blood glucose targets can be very well achieved with insulin. The starting dose, the various types of insulin that we use are short-acting regular insulin. Onset is within 30 minutes and lasting for 6 to 8 hours. We use intermediate-acting NPH. The onset is within 1 hour and lasting for 10 to 14 hours. And then we can use the latest rapid-acting Lispro and Aspart. The onset is within 15 minutes and lasting for 3 to 6 hours. The total requirement of insulin the starting dose is usually 0.6 unit per kg body weight. It can vary up to even 1 unit or even further depending upon the gestational age and glycemic control and obesity. So in first trimester, usually 0.6 kg per day. We start with 0.6 kg per day. In second trimester, 0.7 kg, 0.7 unit per kg per day. And in third trimester, we start with 0.9 unit per kg per day. And then we titrate according to other glycemic control. The normal regime that we follow, the total insulin requirement for the day is divided into 2 parts. 2/3 of it is given in the morning, of which 2/3 should be NPH and 1/3 should be short acting. And then 1/3 of the total insulin we require is given at night, of which 1/2 should be NPH, which is given at bedtime, and 1/2 should be short acting regular insulin, which is given pre-dinner. Then daily testing of blood glucose and blood sugars is done, and ketones by dipstick method is done. So, but this regime can change if it will depend on the various which blood glucose levels are deranged. If fasting blood glucose levels are high, sometimes a single shot of a high intermediate acting insulin at bedtime can suffice. If postprandial levels are high, then we have to give regular rapid acting insulin before the meals. But if both fasting and postprandial levels are high, then we have to initiate a 4 injection per day regime. In this 4 injection per day regime, the insulin is divided into 2 parts. 45% is given as NPH insulin and 55% is given preprandial regular insulin. Of the NPH part, 30% of it is 30% is given before breakfast and 15% before dinner. And of the regular insulins, 22% is given. The highest is given before the breakfast, 18% is given before lunch, and 14% is given before dinner. It has been seen that this 4 times daily regime has improved glycemic control and perinatal outcome as compared to the twice daily regime. Now, if the patient has been started on insulin therapy, then our target blood glucose levels should be 60 to 90 milligrams in fasting, and pre-lunch and pre-dinner again 60 to 90 milligram percent, and 2 hour post meal it should be less than 120, and during night 2 a.m. to 6 a.m. it should not it should be more than 60 milligram percent, should not go below that. Hypoglycemia can be very dangerous. So this was about the insulin therapy. So though insulin is the preferred first line agent for this persistent hyperglycemia, but ACOG and ADA have supported the efficacy of these two oral hypoglycemics as well, which include metformin and glyburide. Though insulin is superior to both of them in various trials done between the insulin and glyburide, it was seen that this fetal macrosomia was more with glyburide, and risk of neonatal hypoglycemia was more with glyburide. And in again in trials of insulin versus metformin, which there were 6 major trials for that, again insulin was found to be superior, though metformin caused less maternal weight gain. It there were the chances of this fetal macrosomia were less, but the overall targets, the blood glucose targets were better achieved with insulin. And but in trials in which glyburide and metformin were compared, though the failure rates with glyburide were lesser, but the goals were achieved better with this maternal weight gain, and macrosomia goals were better achieved with this metformin. Also, the incidence of neonatal hypoglycemia, which can be very dangerous, was lesser with metformin. FDA still has not approved oral hypoglycemics, but ACOG recognizes both as reasonable choices, because there are patients often will prefer tablets or oral hypoglycemics to injectable to insulin. So there are many patients who will prefer oral hypoglycemic. So we can safely give these drugs to them, but after proper counseling, which is recommended, because there are still not the safety profile has still not been fully evaluated. So it can be definitely recommended after proper counseling of about the limitation of our safety profile, these studies in these patients. NICE 2015 guidelines say that pregnant women with type 2 diabetes and gestational diabetes who are on diet or exercise therapy or taking oral therapy or single dose intermediate or long acting insulin should check their fasting and 1 hour post meal blood glucose levels daily, just twice they have to check. But women who are on multiple daily insulin injection regimes, they have to check their fasting, pre-meal, 1 hour post meal, and bedtime blood glucose levels daily. The obstetric management, fetal surveillance, very important in these patients, because um, uh, we have to check for the we have to detect the congenital malformations and macrosomia at the earliest, and any forms of fetal this compromise at the earliest. In first trimester, first USG for confirmation of viability is advised. Then a second USG at 11 to 14 weeks for nuchal thickness. If it is more than 3.5, the chances of the baby having cardiac anomalies is increased.
Dr. Samia, can we hasten up a little? We are behind time.
Yes, ma'am.
Can we hasten up a little? We are behind time. We have already lost a lot of time.
Okay, ma'am. Okay, ma'am. So in second trimester, I'll say level 2 ultrasound at 18 to 20 weeks. Then a fetal echo is recommended only in those patients where there is increased nuchal thickness, where there was poor glycemic control in first trimester. These two are important, or any abnormality shows on level 2. Third trimester, this surveillance, where patient is to be educated about the daily fetal kick count, and then 4 weekly monitoring of the fetal growth at 28 to 36 weeks, especially the abdominal circumference is very important. The timing and mode of delivery in these patients controlled on diet there is no requirement for early intervention in these cases. We can very well wait up to 40 weeks, 6 days for spontaneous labor to start. In when well controlled on medication, delivery between 38 weeks to 39 weeks is recommended, though there are still controversies, but because of the slight increase in the incidence of shoulder dystocia, the elective induction in these is recommended. And in poorly controlled, beyond 37 weeks to 38 weeks, labor initiation of labor is induction of labor is recommended. Per se, GDM is not an indication for cesarean section. The cesarean section is only done for any obstetric complications. So I'll skip the main important during labor is that the level blood glucose level should be maintained. It can be maintained by rotating glucose containing and glucose free intravenous solution. Insulin infusion should be started as per the blood sugars. The goal is to have 80 to 110 milligram percent this blood glucose levels. If the blood glucose exceeds 25 milligram percent, we have to give we have this 50 units of insulin is added in 50 ml of normal saline, and the 5% dextrose which we usually start alongside with it is to be skipped. It is to be changed with normal saline. So if blood glucose levels are up to just 100 milligram percent, we do not need any insulin during labor. But if it is more than that, we need the insulin as per the table here. Fetal health is to be monitored, and good analgesia is to be ensured, because pain can definitely stimulate adrenergic pathways and disturb the blood glucose levels. Postpartum, there is sharp fall in insulin requirement. So GDM patient diabetics often do not require any treatment post-delivery. We should do one blood glucose level before the discharge. Then as per NICE guidelines, we should do a fasting blood glucose level at 16 to 13 weeks, and then postpartum, and then annual fasting blood glucose test. But as per ACOG, the screening should be done at 16 to 13 weeks, 6 to 13 weeks by 75 grams OGTT test. And this test should be repeated every 1 or 3 years. So I'll now rush to GDM in Kashmir. So like elsewhere in India, diabetes is a major public health problem in Kashmir. And in parallel with rising prevalence of diabetes, there is an increase in the prevalence of GDM as well. And in our low resource setup, and because of the limited number of studies that have been done, we do not have much of data, and a large chunk of our patients remain unrecognized. But despite these, the amount of studies, the number of studies and research that we have done has still shown a steep rise in GDM in Kashmir since last 5 decades, from 3.8% in 2004 to 7.8% in 2012. In 2004, Professor Hamid Zargar et al. Conducted a prospective study involving 2,000 Kashmiri women in SKIMS Medical College and found the overall prevalence rate of 3.8%. Prevalence was increased with age from 1.7% in women with less than 25 years of age to 18% in women with more than 35 years of age. The other risk factors, it was higher in urban dwellers, higher in women with history of abortion, higher in para 3 and above, and higher in history of. So essentially the risk factors were found to be the same as in the rest of India and the rest of the world. In 2012, another study was conducted in GDM and GMC Srinagar by Malik Raja et al. Under the esteemed guidance of our esteemed principal Professor Samia Rashid in an urban block of the valley, and it was found the prevalence of GDM was found to be 7.8% that time. Presently, very recently, Shahnawaz Mir et al. And GMC Srinagar conducted a study on prevalence and predictive factors of postpartum diabetes in women with GDM, and they found a very high prevalence of 18% as pre-diabetic in these patients, and 13% of diabetes, overt diabetes in these patients. So certain predictive factors were that insulin dose at term, if it was 0.8 unit per kg body weight.
She lost the connection.
Okay. Thanks. You lost the connection?
Yes, madam. She lost the connection.
Okay. Anyway, I think I would like to thank her. I would like to thank Professor Samia Muthi for an excellent presentation of a complex disease, and also thank the chairpersons, Professor Nighat and Professor Avida. Since we are behind the schedule, I'll just rush into the next, and which is the main focus of today's session. That is long case presentation on hypertension in pregnancy by our third year PG, Dr. Iman Majid. The external examiners are Professor Sudha Sharma. She's from GMC Jammu. She has recently retired as a professor there. She has been General Secretary of Jammu and Jammu Obstetrics and Gynecological Society and Indian Menopause Society Jammu chapter, and has organized various conferences, and active member of FOXY, and as Professor Mahapatra said, an excellent teacher. And next examiner is Professor Dr. Mehbooba. She is Associate Professor in King's Medical College. She's a dynamic and young gynecologist and a very efficient gynecologist. Our internal examiner is Professor Nihal Firdos, Professor and head of the Unit Department of Obs and Gynae in our GMC Srinagar, a highly admired, efficient obstetrician and a great teacher. Over to you, Professor Nigrat.
We can see your presentation, Dr. Emin. Kindly start.
Presentation, we are already behind, and I would like to ask the teacher that we have 10 minutes for the 10 minutes for your question, because we are running behind schedule.
Good afternoon, everyone. Good afternoon. Am I audible?
Yes, yes. Go ahead.
Respected teachers, dear colleagues, a very good afternoon. I am Dr. Iman, postgraduate third year, Department of Obs and Gynae, GMC Srinagar. Today I'll present a case on hypertensive disorders in pregnancy. My patient, Mrs. Mehjabeen, is 32-year-old female belonging to Rainawari, Srinagar. She is a homemaker and a graduate. She is married to Mr. Sajad, who is teacher by profession, and they belong to Kupuswamy. As per Kupuswamy's scale, they belong to lower middle class. Her LMP was on 26th of April 2020, and her EDD is on 2nd of Feb 2021. She presented to our hospital with the chief complaints of 8 months of amenorrhea with swelling of bilateral lower limb since 10 days. Patient with 8 months of amenorrhea was apparently normal 10 days back when she started noticing swelling of both lower limbs, which was aggravated by physical activity. There was no diurnal or postural variation. It was present throughout the day and not relieved by rest. There is history of increased BP, but she was not on any treatment. There is no history of headache, blurring of vision, syncopal attacks, no history of reduced urine output or hematuria, no history of epigastric pain or nausea, vomiting, no history of jaundice or ascites. Her first trimester was uneventful. Pregnancy was diagnosed by UPT at home after 6 weeks. She was started on folic acid supplementation. All baseline investigations and ultrasound scan was done. which confirmed live gestation and age corresponded to her LMP. There was no history of vomiting, fever, rash, pain, abdomen, UTI, bleeding, or spotting per vagina. And there was no history of increased blood pressure, no history of any drug or radiation intake. In second trimester, quickening was felt at fifth month of gestation. She was started on iron and calcium supplementation. She received 2 doses of tetanus toxide. Anomaly scan was normal. Her oral glucose tolerance test was normal. There was no history of increased BP in second trimester, no history of pain, abdomen, pedal edema, headache, or bleeding. Routine antenatal investigations were done and they were found to be normal. Amenorrhea continued with progressive enlargement of abdomen. She appreciates fetal movements well. She continued iron and calcium supplementation. There is history of increased BP, but she was not on any treatment. Now she reported to hospital with complaints of bilateral lower limb edema. Her menstrual history, she had history of regular cycles with normal flow. Her LMP was on 26th of April 2020, and as per Nigli's formula, her EDD was on 2nd of Feb 2021. Her period of gestation was 33 weeks as calculated on 13th of December. She's married for 5 years, non-consanguineous marriage. She's gravida to Paravan Livan. Her last childbirth was 4 years back. She had a full-term normal vaginal delivery of a live male baby, weighing 2.8 kg at LD hospital. There was history of gestational hypertension as per records. There was no antenatal, intrapartum, or postpartum complications. On postnatal follow-up, BP was normal. There is history of using male barrier contraception, and this pregnancy was as a result of spontaneous conception. There is history of gestational hypertension in previous pregnancy, but there is no history of diabetes, tuberculosis, epilepsy, or thyroid disorders, and surgical history was not significant. Family history, there was no history of diabetes, hypertension, tuberculosis, or thyroid disorders in any of her family members. She is a non-vegetarian, sleep, appetite, bladder, and bowel habits were normal. Now coming to the examination, she is moderately built and nourished, conscious, alert, cooperative, well-oriented to time, place, and person. Her pulse rate was 86 beats per minute. It was regular with good volume, and on admission, her BP was 150 by 100 mm of Hg. With the respiratory rate of 16, there was no pallor, icterus, or lymphadenopathy, but edema was present. There was bilateral lower limb edema, which was pitting in nature, and there was periorbital edema also. Rest of the examination was normal. Her BMI was 29.1. Systemic examination, respiratory system was normal, CVS, CNS, all were normal. And on obstetric examination, on inspection, abdomen was uniformly distended, flanks were not full, umbilicus was everted, stria gravidarum, albicans, and linea nigra were present. There were no scars over the abdomen, and hernial orifices were normal. On palpation, she was examined in supine position with legs semi-flexed. Fundal height corresponded to 34 weeks of gestation. Symphysis fundal height was 32 centimeter. A fundal group was suggestive of breech. Lateral group, on right side, there were knob-like structures suggestive of limbads. On left side, there was a uniformly curved resistance suggestive of spine. First pelvic group was suggestive of head, felt at lower pole. And second pelvic group, the findings of the first pelvic group were confirmed and head was unengaged. On auscultation, fetal heart sounds were heard along the left spino-umbilical line midpoint. Rate was regular. Investigations were done. She is Rh positive, with the blood group is O positive, with the HB of 10 grams per deciliter. Her counts were normal. AST was 60, LT was 70. Electrolytes were normal. Her LDH was 400. Spot urinary protein was 2 plus. Coagulo and one weeks 2 days. Placental localization was fundal. Liquor was adequate. Her fetal weight was 1.8 kg. And on color Doppler, she had a persistent diastolic notch in left uterine artery. So my provisional diagnosis is 32-year-old Mrs. Mehjabeen, gravida 2, para 1, live 1, at 33 weeks of gestation, Rh positive, with single live fetus in longitudinal lie, cephalic presentation, and blood pressure of 150 by 100 mm of Hg, with proteinuria due on 2nd of Feb, suggestive of non-severe preeclampsia. So now the question is whether to treat her as inpatient or outpatient. It depends on her blood pressure, depends on the fetal well-being and proteinuria. In the above
Hello?
scenario,
Can you hear me?
yes,
Yes. To our respected teachers and dear student, I think your presentation is finished as soon as you say the diagnosis summary. Okay, the management will be asked by the crossing.
With
By the exam.
examiners.
Okay,
Yes,
so I think it is
that's right.
going to be a presentation not of a long case but of a lecture. So you
Mm.
better stop at provisional diagnosis. In case you have some differential diagnosis, investigation, that's okay, but you're not going to management. Okay,
okay, sir.
is it okay? Dear teachers.
It's, it's okay. It's okay. Yes, we should stop here.
Yeah. Another point I just wanted to make here. Can you see me? Can you hear me?
Yes, sir.
We can hear you.
Ah, okay. Actually, the presentation of a long case is very important for a student, and it is not the reading out of the entire history sheet and the unimportant findings that will not hold the patience of the examiner. I don't know what is your system of examination there, but in most of the universities, the external examiners will not have this much of patience to hear out the entire story and the negative stories and positive findings, etc. So it is important that your students should
Highlight.
present a good summary of the case containing all the important positive findings in short and the important negative findings. And so that because when she presents the case, the sheet will be taken away by the examiner, isn't it? Isn't it the practice
Yes,
during
that's right.
examination?
That's what it is normally.
Yeah.
Also.
Yeah. And secondly, so I think they should be able to make a good summary of the case and present it to the examiner.
Yeah, that's what they do. That's what they do, because
Yeah.
in the as postgraduates, they are just, even in the undergraduates, they are just asked a one line. Would you summarize your diagnosis in one line?
The usual
That's
question is, what is your case? And then the
yeah,
postgraduate will be able to
yeah,
make
the case.
yeah. Acha, I would like to make another comment about the provisional diagnosis. You see, it should be as short and precise as possible. You see, there are a lot of extra informations which may not be necessary for a provisional diagnosis. For instance, what is the need of writing the EDD due 2nd February 2021 if you say that the period of gestation is 33 weeks? It is not necessary in the diagnosis. Similarly, single living fetus in longitudinal lie cephalic presentation. When you say cephalic presentation, it is already implicated that it is a longitudinal lie, isn't it?
Yes,
Right.
sir.
It cannot be anything else. Okay, so make the
Sometimes the case.
provisional diagnosis as short as possible, as crisp as possible, so that it should not look like a summary. The present provisional diagnosis is looking almost like a summary. Okay, so there are two
Actually,
important messages I would like to convey to your students and my dear teachers. You carry on, please, with the crossing.
Good evening, everyone.
Um,
Am I audible?
Yeah,
Yes,
yeah,
ma'am.
you're audible,
Yeah.
audible.
So,
Good
I
evening.
just okay. Good evening. I
Good
want to
evening. Start.
first,
Yeah, yeah. You
first
just
congratulate Dr. Mahapatra, who is the brain behind these tutorials. Wonderful sessions, and Dr. Ashish for execution of all these tutorials, and the Srinagar team also, Dr. Farad and Dr. Rizwana for bringing all of us together on this virtual platform to update ourselves and to interact. Such a wonderful evening, I must say. Congratulations to Dr. Iman also. She has presented it beautifully, this case summary, along with history and examination. And also, Dr. Ashish, you have added so many good points for these postgraduates. So they now can present it in a better way, in a shorter form, and in a concise form. So, Dr. Iman, you have taken a beautiful history. I just want to add just 2 points. You said that she has presented with pedal edema. So, uh, you should have asked her how much weight gain she has gained during this time, because edema is now no longer considered as a
Criteria.
diagnostic criteria for PIH. So we all know that excessive weight gain, more than 4 pounds per week, if at all is there, then we can consider that this patient is a candidate of, can be a candidate of PIH. And then second thing, in your personal history, you have asked her past history, history of diabetes, tuberculosis, anything. I think you should have asked her any history of renal disease or vascular disease pertaining to these PIH cases. That is more important in these cases as compared to this tuberculosis and thyroid history. So I want to ask you just few things, very, very basic things that you tell me. How do we measure what is the right position of measuring blood pressure in a female, in a pregnant female?
Ma'am, in
Mm.
OPD settings, we usually measure the blood pressure in sitting position.
Mm-hmm.
And in inpatient settings, the best way to measure the blood pressure is in lateral recumbent position, lateral decubitus position.
Lateral decubitus position, yes. Number two, what is the best instrument to measure the blood pressure?
It's the mercury
Very, very
sphygmomanometer.
basic thing, but very practical.
It's actually mercury sphygmomanometer, but usually nowadays we use digital BP apparatuses with
But the best one is,
mercury
yes, this is the mercury.
sphygmometer.
Yes, yes. Uh, Also, you have told us that, and the third thing I want to ask you, which phase we are taking into consideration? Korsakoff phase 5 or phase 4?
No, ma'am, we take phase 5 as a cutoff point. That is the
Mhm.
muffling of sounds. That's phase 4 is no longer taken as the end point. We take phase 5 as the end point
As
of
the enhancement.
for
Yes, very
measuring
good.
diastolic blood pressure.
Yes. You have also told us that she has a history of gestational hypertension in the previous pregnancy.
Yes, ma'am.
Is it? So you think that she could be a case of PIH in this pregnancy also?
Yes, ma'am.
Yes. So
There
first tell
is
me, yeah, how can you predict PIH in a patient, in a pregnant patient who has presented to you in early pregnancy?
we have many we have different predictors of PIH, but they are not reliable. Uh,
Hmm.
we have we can do certain tests like rollover test at 30
Just
weeks,
name the test.
rollover test. We have isometric hand grip exercise. We have Doppler velocimetry,
Hmm.
in which
So what
there
is
is
the test which is most reliable and which we are carrying on in these days?
that's color Doppler
That is color Doppler. When it is to be done?
at 28 weeks.
Is it to be done in all the cases?
No,
Is it a screening?
only in high risk cases. Those patients who
Only.
are at high risk of hypertensive disorders in pregnancy.
Okay, okay. All those cases who are high risk cases. You know, anything which is very, very recent, which comes in the Doppler studies also, they have now suggested, no doubt it is not in the formulation or in the screening methods, but any idea recently uh, they have thought that Doppler studies, if done earlier, could be
18 to 20 weeks. At 20 weeks.
it is 11 to 13 weeks, and wherein we see the impedance to flow. If it is increased, then we say that she could be a case of PET later in the pregnancy. Uh, so now we knew that she is a case of PIH. She could be a case of PIH if she presents earlier because she has a previous history of. What preventive measures you could have taken
Ma'am,
knowing that she is.
as per recent guidelines, it has been seen if low dose aspirin is given to the patients who are at high risk of developing hypertensive disorders of pregnancy, it can prevent the preeclampsia to certain extent. Low dose,
What,
I mean,
how does it help? How does aspirin help?
ma'am, actually, aspirin, it's a COX inhibitor. So, am I audible?
Yeah, you are.
Yeah, you're audible.
Ma'am, if we go to the pathophysiology of preeclampsia, actually there is endothelial dysfunction. So there is release of thromboxanes and there is a decrease in the prostacyclins, which act as vasodilators, and these all are developed from the arachidonic acid. So if we give aspirin, that's a COX inhibitor. So there will be prevention of development of these thromboxanes, which are the platelet aggregators and which act as vasoconstrictors. So this may be the mechanism which may prevent the early development of preeclampsia.
So what time do you start this aspirin?
Can be started as early as 12 weeks and continued up to 36 weeks.
Okay. Any role of calcium? Do you know what are the WHO guidelines on calcium supplementation for prevention of PIH?
Ma'am, there have been studies about calcium supplementation, and it's advised that around 2 grams of calcium to be given.
WHO has given certain guidelines. WHO has given guidelines in 2016, which were updated in 2018. They gave guidelines first in 2016. They were updated in 2018 regarding calcium supplementation. So you have any idea? Tell me.
Oh,
Yes, you were speaking.
Ma'am, regular calcium supplementation, 2 grams per day, it can prevent the development of severe preeclampsia.
How does it help? Any idea?
Ma'am, it has been seen that I'm not sure about it.
This decreases the release of parathormone hormone and the intracellular calcium concentration, which results in decreased smooth muscle contractility.
Okay.
So the dose is 1.5 to 2 grams, and you can start it. Any idea of timing of initiation?
Second trimester?
No, you should start it as early as possible on the first antenatal visit only in these cases. Any role of vitamin D beta in prevention? Have you heard of vitamin D in prevention?
No.
No idea. Dr. Iman, can you hear me? Dr. Iman,
Hello.
can you hear me?
Yes, ma'am.
Any idea of vitamin D in prevention of preeclampsia?
Uh, Ma'am, vitamin D supplementation, it has been studies have been done that it can also help in prevention of preeclampsia, severe preeclampsia.
See, they have seen that vitamin D, low maternal vitamin D, they have seen that it can create problems as low birth weight babies, small for gestational babies
Growth
in these females.
restriction.
So the recommendation, though, so hypervitaminosis has been seen to be associated with preeclamptic toxemia. So we can start vitamin D also, but it's not proven as yet. So we need more studies
Studies
to
for
see the
prove
role of vitamin D in the prevention of preeclampsia.
preeclampsia.
And then we can say, how are you going to manage this case? I think my co-teacher can ask these questions.
Hello.
Hello.
Can you
Hello,
hear
sir.
me? Hello.
Hello. This
Can
is
you?
Dr. Mehbooba. A very good afternoon to you. And a special thanks to Dr. Mahapatra sir, Ashish sir, and to my faculty, my senior faculty, Dr. Rizwan, Farhat ma'am, and Sudha ma'am. Thank you very much, ma'am, for inviting me. Now, can I proceed with the questions? I want to ask few questions to Dr. Inam. Dr. Inam,
Yes,
are you
ma'am.
ready?
Yes, ma'am.
Dr. Mehbooba, before you
Yes, sir.
proceed, I just wanted to put a few points
Okay, sir.
about the crossing done so far. This is for discussion also, and also for the students and the teachers as well.
Yes, sir.
3 points that were discussed, but rest all of the points were okay. One point was a BP measurement. Should it be done in which position? What the candidate should answer. Okay.
Yes,
And
sir.
here I would like to put a different view about the measurement of blood pressure in pregnant women.
Yes, sir.
Um, Usually we used to measure the blood pressure in the indoor settings in the left lateral position. But unfortunately, left lateral position BP measurement may give rise to falsely low values at
Low,
times.
yes.
And therefore, now it is recommended that measurement of blood pressure in a pregnant woman should be always done in the sitting position.
Sitting position. Yes.
Only thing is that you should see that the legs are not crossed.
Yes, sir.
And in the OPD, be it in the indoor, always you should ensure that the patient is in sitting position. That's not only because you will see the correct level of blood pressure, but it is also because of the fact that that is the position she assumes most of the times of the day. That means that you will get the actual blood pressure, exact blood pressure, which is happening inside the body of the patient for most of the time of the day. So I think the students today should answer that irrespective of whether it is in the OPD or in the indoor, they should always measure the blood pressure in the sitting position, but the legs should not be crossed. The patient should be rested for 15 minutes prior to the procedure, and they should be worries and anxieties free. She should not be talking for last 15 minutes, which is very difficult for a lady to hold. And also she should not have any, nasal decongestants or other things. So these are the preconditions for measuring the blood pressure. And I think the PG students should know this. Secondly, there was one question was asked about which machine is ideal for the measurement of the blood pressure. These are all basic things. I think that's why I am taking up these points. The gold standard is, of course, sphygmomanometer. There is no doubt about that. And the PG student should always say this sphygmomanometer is the gold standard. But the problem is that Pollution Control Board of India has put a ban on all mercury containing devices. So the students of today should know this, that today they have to find out another alternative for the sphygmomanometer and keep it as a reserve. Because whenever there's a question of your blood pressure equipment, if the Pollution Control Board examines that you are using a mercury containing device, that is for all practical purposes forbidden by the Pollution Control Board. I don't know about J&K, but in our state, it's a strict ban in our state. Okay, so you have to think about that also. Third point was about the Korotkov point, 4 or 5. Yes, the student said that always you should see the Korotkov 5 sound. That means disappearance of the sound. That's true. But in 5% of cases, you will see that in pregnancy particularly, the sound continues up to the 0 level. In only 5% of cases, that may so happen that the sound continues up to 0. And in these cases only, you have to lift up the mercury level once again and now see the muffling sound or Korotkov 4 sound. So ordinarily it is the Korotkov 5 sound, but only cases where the diastole goes down up to the 0 level. Diastole cannot be 0 under any circumstances. So those cases you have to re-inflate the cuff and then check the diastole level at the muffling or the Korotkov 4 sound. Is it okay?
Yeah, it's okay. But I would like to add here that we are running out of time.
Yeah. So no, I thought that these points are very important from the student's point of view.
I'm grateful for you to
I
point
think,
out.
I think it is good. It is good. At least let us have this sort of a thing, intervention in between, so that our students are, at least they know where they
No,
have to change their way of presentation.
I
Yes,
just
Dr. Ashish, they are very, very practical answers because probably they are not written in the textbooks, so the students do not know it. But it is good that you have brought them into the discussion.
I think these are more important because there are many things students don't know about the theoretical parts and other investigations and all those things. But the practical points, if they ask, the examiner asks the question, then the student gets baffled. That's why I feel. That's why I saw.
And because I think we are dealing with patients day in and day out, these PIH patients, and these are the practical points, though they are very basic, but they are very important.
Very basic points, yes.
And the text.
Right, sir.
Yeah.
Dr. Inam?
Yes, ma'am.
Dr. Inam?
Yes, ma'am.
Can you hear me?
Yes, ma'am.
Can you tell me, beta, what is the relevance of home monitoring of BP in hypertensive patients?
Ma'am, there is an entity. Ma'am, you are talking about those who are already diagnosed with hypertension?
Yeah, we have diagnosed them as hypertensive patients.
Ma'am, usually in gestational hypertension, we advise the patient for home monitoring of BP. So we tell them about the ominous signs of preeclampsia, and if the BP goes more than 150 by 100 mmHg, though they have to report to the hospital. So that's why it's important to measure the blood pressure at home. And there is another entity, white coat hypertension. So if we diagnose a patient in our OPD with hypertension, maybe it's because of this entity.
Anxiety part, it may be because of anxiety.
Anxiety,
part.
yes.
Then how do we overcome how they are to be advised for home monitoring? How they have to take this reading? It is to be done once a day, or they have to take it morning, evening? Because there is circadian rhythm of BP.
Yes, ma'am. Ma'am, we tell them to take 2 readings, morning and evening, after 30 minutes of rest in a quiet place, after resting in a quiet place. And the circadian rhythm, of course, there is the BP is lowest during the night and maximum in the morning between 6 a.m. and 8 a.m. There's the highest rise of BP.
Okay. Then what happens in the evenings?
During the night, during the night, there's the nadir of BP. Lowest readings are during night, usually around 3 a.m. to 5 a.m.
So does this help, this home monitoring, does this help in these patient, in treatment part of patients?
Yes, ma'am.
Okay, it can help. Now, at what level of BP you have to start with the antihypertensives?
As per recent recommendations, we start antihypertensives at 150 by, if BP is more than 150 by 100 mm of Hg. at 2 or more occasions. But in patients with chronic hypertension or who have already certain complications, or in those patients, we start at 140/90. If there are
Okay.
kidney, yes, ma'am.
Now, what are the advantages and disadvantages of starting with the antihypertensives?
Advantages, obviously, if we start with antihypertensives, it will prevent the complications of severe eclampsia, because our BP will be controlled. So the complications like pulmonary edema, we have different complications like pulmonary edema, we have cerebrovascular accidents, or other complications, they will be prevented if we have a controlled blood pressure.
Are there any disadvantages? We are unnecessarily putting the patient on antihypertensives.
Ma'am, disadvantages may be the side effects related to the drugs, and
Any other problem that can happen to the fetus because we are putting mother on antihypertensives?
yes, there can be uteroplacental insufficiency due to
No, it
vaso.
doesn't happen. Uteroplacental
Sorry.
insufficiency is not there, but once you are putting the patient on antihypertensives, she can have. Does anything happen to the growth of the baby?
Growth restriction, fetal growth restriction.
So, what is the ideal level of blood pressure when we have to put them on
As
antihypertensives?
our goal is to keep
Should
blood
be
pressure below 135/85 as per recent NICE guidelines.
80 to 100 should be the diastolic blood pressure,
Yes,
and
ma'am.
above 150 we have to treat. But there is no confusion after 150 or more than 110. There is no
We have to
confusion. We
start
have to
with.
give them the treatment. So your patient is 33 weeks of pregnancy. Now, how you will proceed in this patient?
First of all, will admit the patient for all we'll investigate the patient. Then we'll do fetal and maternal evaluation. Maternal
Okay.
evaluation will include all the baseline investigations. It will include urinary examination, dipstick. Then we'll rule out any causes of chronic hypertension. Then fetal evaluation, and will recheck her BP, and then put her on antihypertensives. And fetal evaluation includes monitoring the baby by, it can be by daily fetal movement counting, or we can go for non-stress testing, AFI, which is usually recommended to be done twice weekly. We can go for periodic growth scans and color Doppler studies. And will also educate the patient about the ominous signs of preeclampsia, which include headache, blurring of vision, epigastric pain, vomiting, etc., decreased urine output.
Okay. Then how will you terminate her pregnancy and at what gestation?
As she is a case of non-severe preeclampsia, we can carry the pregnancy up to 37 weeks of gestation. But if at any point of time we have any sign of severe preeclampsia, we have to terminate the pregnancy at that point of time. In this case, we'll carry the pregnancy to 37 weeks of gestation, and then after proper pelvic examination, and just ruling the other after proper pelvic examination, bishop scoring, we can induce the patient with prostaglandins, and we can go for vaginal delivery in this case, as she is.
Okay. Do we need to keep her admitted in the hospital or we can discharge her?
We can discharge her because her BP was controlled on, we started her on labetalol 100 BD. Her BP was controlled, so we can discharge the patient, and she can come for weekly visits.
And at visits, what you will be doing? What you will be checking?
At each visit, we'll check her blood pressure, we'll check her weight, urine for spot urine for proteins, And we can go for all baseline investigations, including KFT, LFT, if there's any derangement in LFTs or KFT. And obviously the fetal assessment, fetal heart
Okay.
rate. Yes, ma'am.
If she is not, her baby is not gaining any weight and she is showing any signs of dangerous signs of this preeclampsia, then how will you proceed in her?
If she is proceeding to dangerous signs of preeclampsia, then we'll give her corticosteroids and will terminate the pregnancy.
Okay. Okay, good. Yeah, ma'am, I'm done.
Yes, Dr. Rizwana, I think we can move on to next session.
Yeah, I would like some inputs from Professor Mahapatra and Professor Ashish in this case, because it was really a very good discussion. Though we are running out of time, but now let's have some input from both of them.
No, I think it was a very good case discussion, fantastically done. Only just a little bit of modification this side or that side. And presentation of the cases by the students, I just want to, be it a summary form, so that the PGT learns how to present a case. This is the first platform that they get in the form of
Yes.
examination for the future life. So I just wanted that a summary should be presented to the examiner, and then the crossing starts. That's the right way to do that. That's what I said. I think this case was wonderfully done. Thank you very much. And Dr.
Thank you, sir.
If Dr. P.C. Mahapatra has to say something, then otherwise we'll move to the next.
Can we move to the next case?
I think so.
I think we can move on to the next case, and then we can ask questions which were not covered so far.
Assalamu alaikum.
Assalamu alaikum, ma'am.
How are you? Dr. Ashish, we are here again on same platform.
It's such a pleasure hearing you once again.
Yeah. VHU we met.
I remember VHU.
Yeah.
Yes.
Yeah. Actually,
Dr.
today
Seema, Assalamu alaikum.
Very elaborate CME on ovarian cancer. So it just finished.
Okay.
From cancer, we have to come to an antenatal case, but anyhow. Let's hear the case. Postgraduate, whosoever is present.
So our next case is a short case of gestational diabetes.
Yes.
And the external examiner is Professor Seema Hakim.
Please don't introduce me. Start with the case.
Okay.
I don't want to waste any time.
Dr. Seema needs no introduction. She's an international figure.
Doesn't need any introduction. That I understood long ago.
Let's start with the case.
Teacher. So nothing really doesn't need any introduction. Our next examiner is Dr. Simona, and I am the internal examiner. So let's speak. And the case is being presented by Dr. Muzammil, third year.
Okay.
Muzammil, please present your case. Dr. Muzammil, please present your case.
No, Dr. Muzammil. Yeah. Now it's. Yeah.
Go ahead.
There are some technical issues.
I think instead of sharing the slide, you can start. We will hear. Because we'll be wasting time then. Let's start. It doesn't matter. If you are not able to share the slide, it's okay.
In exam, you won't get a slide.
Yes.
No, it's
Yes.
now visible. Kindly unmute yourself. I have sent a request, Dr. Muzamil. Yeah.
Acha, one thing I would like to say, like, these days you don't start with that, I am going to present a case of gestational diabetes
Okay.
or things like that. You just can say that I am going to present an antenatal case. So once we hear your presentation, and then we will ask you that what do you think your patient has got. So it is always a bad habit to present the case with a diagnosis in mind, because any patient will not have one diagnosis only that is to be managed. We will have to see the case as a whole and manage the case as a whole. So I think maybe you are told like this, but whenever in future you present a case, just keep this mind that this is not a case of diabetes that I have got. I have got a woman who is whatever age,
Antenatal.
has a pregnancy, and now I will have to work on her, and will have to find out what all problem she is suffering from. Dr. Ashish, am I right?
Absolutely, absolutely
Yes.
right, madam.
So let us hear from Muzammil what she has to say about her case.
Assalamu
Yeah.
alaikum. Very good afternoon, everyone.
Good
I'm
afternoon, Muzammil.
I'm Dr. Muzammil, postgraduate third year student, Department of Obstetrics and
Go
Gynecology.
ahead, go ahead, go ahead.
Okay, ma'am.
So again, like, you don't have to introduce yourself again and again. We have seen that, and start with the case.
A 38-year-old female, namely Mrs. Arifa from Badwan, Badgam. She is housewife by occupation. She is belonging to lower middle class according to Kopasomi socio-economic scale. She is gravid to para 1 live 1. Her last menstrual period was on 30th March 2020 with expected date of delivery on 6th January 2021. She was admitted on 10th December 2020. She is 36 weeks 4 days on the day of admission. The patient was referred from SDH with 9 months of amenorrhea with deranged blood sugars, not controlled on oral hypoglycemic agents, and hence admitted in our hospital for further management. She also complained of abdominal heaviness and polyuria. In first trimester, she has a spontaneous conception. There is no history of excessive vomiting, bleeding, or spotting per vagina. There is no history of fever, UTI, radiation, or drug exposure. Folic acid tablets were taken regularly. Patient went for routine investigation at local hospital, and all investigations were normal at booking visit. First trimester scan was done, which was normal. In second trimester, quickening felt at 5 months of amenorrhea, anamly scan done,
Just a minute, Muzammil. In first trimester, you said that a scan was done, which was normal. Instead of saying that, you could have said that first trimester scan was done and her dates correspond with the gestational age, which was there on ultrasonography. Or if it does not correspond, you can say that, and it was a singleton pregnancy or multiple pregnancy. So instead of saying that normal, you could have said that if the report is given to you. And if you do not have the report, you can't comment on that. You can just say that she had a first trimester ultrasound and the report is not with her. Okay. Got the point? Instead of saying what we are interested to know, that whether it corresponds with the gestational age, whether she had a singleton pregnancy or a multiple, as she is 38-year-old, at what gestational age was it done? Was it done between 11 to 13 weeks to comment on to the neural, to that nuchal fold thickness? So all these things will be better to comment on, and if it was done just she missed her period and it correspond, it's okay. So don't call it a normal or abnormal, isn't it?
Okay, ma'am.
Right, go ahead. So second trimester, just we'll see that what all you have written. Okay. So she had a history of increased sugar on, she was diagnosed as a case of diabetes. You said that,
Gestational diabetes mellitus.
yeah. Why do you call it a gestational diabetes? In first trimester, did she have her sugar level done, or did you call it a GDM at this point of time? Who is 38-year-old and she is gravida 3?
Gravida 2.
Yeah. So
Ma'am,
what made you think that she is a case of GDM?
ma'am, she is a case of gestational diabetes mellitus because they have diagnosed it in the fifth months of amenorrhea. In the first trimester, they have not done it. Maybe they have missed it.
They didn't do it in
They
first
didn't
time.
do it. They
Okay. So what
probably
is
they.
your view? Should it be done in first trimester also?
Ma'am, she is the case of, she has the history of previous GDM. She's
Routine. Suppose the patient is coming to you for the first time in first trimester only.
Ma'am,
should you do a sugar at that time, or you leave it to be done at around 24 weeks?
ma'am, as we lie in the country, India, which is diabetic capital of the world, we have to do it as routine at the first antenatal contact.
Yes. So at
Especially in
this
women
point
with.
of time, I would like you to elaborate on what is inverted triangle of antenatal care. Have you heard of this terminology? Inverted triangle of antenatal care. Was it what this is? Why am I calling it inverted triangle? Normally, what do you do at your place? How many antenatal visit and how do you space those antenatal visit? Just tell me whatever you are following at your place. Don't think that I am here as an external examiner and I am going to do anything bad to you. It is just a teaching learning session and we learn mutually, we learn.
Ma'am, in normal pregnancy, in first trimester, we do it at monthly visit, and in second trimester, fortnightly, and in third trimester, after every week.
Is that followed at your place? It's okay. So what does this inverted triangle says? More visit in initial part, है ना? ज्यादा उसकी visit, जैसे ये patient है, अगर इसकी हो सकता है ज्यादा visit, especially those who are multi-parous or those who are elderly, you do more visit in early part to find out who is at more risk and who is at low risk. High risk, low risk शुरू में भी पता चल जाता है कौन से cases हैं जो ज़्यादा at risk हैं. So this is what is called a inverted triangle of antenatal care. We do not have much time. So I'll request you to note down this and read it today itself. What is the inverted triangle of antenatal care? And for all those who are attending, they should read what does this mean, inverted triangle. So her sugar was not done in first trimester and you are doing it now. And do you know the exact value what it came? Was it a OGTT or were you doing it with the DIPSY criteria?
Ma'am, it was OGTT 75 fasting 1 hour, 2 hour according to IADPSG criteria. She has done it. She has done it according to IADPSG criteria.
क्या कहता है?
Ma'am,
yes.
Ma'am, DIPSY criteria कहता है it should be done. It should be done in all pregnant women whenever she come at the first antenatal visit. It is done irrespective of meal. Whether she comes fasting or not, and we take 1 hour reading after taking glucose 75 grams.
Just make this concept clear ki why this non-fasting was encouraged, because most of the women who are coming to us.
Ma'am, in our country, most of the population lies in the rural, most of the women lie in the rural areas, and they have not, the drop rate is very high because they don't come regularly for antenatal visitors. So it is done irrespective of the meals.
ओके, रेस्पेक्टिव ऑफ मील किया, 75 ग्राम ग्लूकोज दिया, कितना दिया?
Ma'am, 75 gram glucose in 300 ml of water
Okay.
over 5 to 10 minutes.
Okay.
And she should be seated over the whole procedure.
और कब शुगर मेजरमेंट कब करेंगे? 1 hour
Ma'am, after 1 hour of taking 75 gram of
1 hour है या 2 hour है, ये बताओ.
Ma'am, 2 hour, 2 hour.
2 hour है, और कितना वैल्यू कट ऑफ है?
Ma'am, cut off more than or equal to 140.
वेरी गुड. तो जो तुमने 1 hour कहा ना, वो
Ma'am,
ग्लूकोज
वो GCT है.
हाँ, जो 50 ग्राम से करते हैं, जो अमेरिकन कॉलेज ACOG की है, और अमेरिकन डायबिटिक एसोसिएशन का टू स्टेप स्क्रीन क्या होता है, 1 step क्या होता है, ये बताओ. 2 step, 1 step.
Ma'am, 2-step procedure is recommended by ACOG. In this test, in this procedure, we first do screening test with 50 gram of glucose. Ma'am, we give a patient 50 gram of glucose, and after 1 hour of taking glucose, a test is done. If it comes more than or equal to 140, then then 75 gram of glucose is given to the patient.
नहीं, फिर
to
तो
confirm.
नहीं, अगर तुमने 50 का किया है तो फिर 100 दे करके और
100 gram of oral glucose.
फास्टिंग 1 hour, 2 hour, 3
hour.
बट जिप्सी का जो हमारा 75 ग्राम ग्लूकोज 2 hours के बाद लेने का, इट इज गुड एनफ. सो वी आर गोइंग फॉर 1 step और 2 step?
Ma'am, we are 1-step procedure.
अच्छा, ये गाइडलाइन और कहाँ पे है जो कि तुम ऑथेंटिकली अपने आंसर को बोल सकती हो, जो हमारे गवर्नमेंट ऑफ इंडिया की है ना, नेशनल.
Ma'am, it is recommended also by WHO.
Yes, and this booklet is available on the website, so you can download and read this booklet also. ठीक है, this is on nhm.gov.in, government of India की है, ठीक है. So further going ahead with your case, so she had in second trimester the sugar was estimated. Go ahead. What happened in her third trimester then?
Ma'am, amenorrhea continues with progressive enlargement of abdomen. Patient perceives fetal movements well. Growth scan done at 7 months.
Okay.
And it corresponds with gestational age.
Okay.
At routine antenatal visit during 9 months of pregnancy, blood sugars were found to be deranged.
In between, did she have any blood sugar monitoring or no blood sugar monitoring?
Ma'am, she was put on medical nutrition therapy, and she was monitoring her blood sugars
herself.
Ji, ma'am. And after medical nutrition therapy, she was put on metformin 500 milligram BD. She was on oral hypoglycemic agents.
Okay. So what do you think that oral hypoglycemic agent, are they recommended? What does your the textbooks like Williams writes about oral hypoglycemics in pregnancy?
Ma'am,
you all are reading Williams, I guess.
Yes, ma'am.
Yes.
Ma'am, as per recent guidelines, we can recommend, we can give a metformin as a treatment.
ये विलियम्स में क्या लिखा है ये बताओ?
Insulin.
They have quoted many studies, and they have said that you can give it to your patient, but tell her that we do not have enough data to recommend or to repeat, but we do give. Okay.
But first line is insulin.
Okay. Okay, we'll go on to that. Let us hear more about this patient. Let's not jump onto the insulin first. So when she was admitted, what was her sugar profile like?
Blood sugar fasting was 120 milligram per deciliter. Blood sugar postprandial, it was 190 milligram per deciliter. After dinner, it was. She also complained of polyuria. Then she was referred from SDH to our hospital for further management, for optimization of blood sugar.
Okay. So once she came to you, what all investigation you requested on her, apart from the sugar level, which you did fasting, and postprandial, how many hours after her meals?
Ma'am, it was 2 hours post meal.
Okay. And what is this 4-point and 6-point blood sugar, and what are the conditions where you do 4-point or 6-point, और कब करते हैं? जरा इस पे elaborate करो.
Ma'am, 4-point. Ma'am, 4 readings we done it blood sugar fasting.
Yes.
After breakfasting 2 hours.
Yes.
Or 1 hour. After lunch
1 hour or 2 hours?
Ma'am, either 1 hour or 2 hours, but 2
Okay.
hours is most
So what is the goal? What is the goal? How much it should be at 1 hour and how much it should be at 2 hour? Goal kya hota hai?
Ma'am, goal is if it is 1 hour, it should be less than 100. Less than 140. And after 2 hours, it is less than 120.
Okay. Okay. So that should be the goal, right? Go ahead.
Ma'am, then blood sugar after lunch, 1 hour or 2 hour, and then blood sugar after dinner, after 2 hours or 1 hour.
Okay, right. And in 6 point, may you do it before meals also, right?
If we are doing intensive, then it should be done 6 or 7 times a day.
Probably Dr. Rizwana is giving me a indication that we are running short of time. We will finish, Dr. Rizwana, don't worry. But important.
Seema, we are enjoying every question, and this is excellent. Please continue. Time is no consideration.
Only asking for that, we should be given more time. By the
Yeah, I want more.
Thank you.
Want more.
So go ahead. What next? What next?
Ma'am, her menstrual history, she has a menarche at the age of 14 years.
Okay, let's skip it. Let's hear the post-obstetrical history, which is
ma'am, she was married.
A regular cycle?
Ji, ma'am, she has regular past menstrual
cycle. To know the menstrual cycle in these women, can they have prolonged cycles also? If yes, which category?
If yes, PCOS, maybe they have PCOS, associated PCOS.
Yes, so menstrual history was very, very important in this case. But fortunately, you also have a dating scan, first trimester scan also. So here lies the importance of having a dating scan in these women who are, the cycle is not regular, but your patient has had a normal menstrual cycle. That is good. So moving ahead with the past obstetrical history, tell us that.
Ma'am, she's married for the last 6 years. She has non-consanguineous marriage. Her previous pregnancy delivered in 2016. That time it was delivered at tertiary care by lower segment cesarean section, done for cephalopelvic disproportion. Baby was 4.3 kg. She was a female girl. This patient was case of GDM in that pregnancy also, controlled on oral hypoglycemic agents till term. She has history of NICU admission for 3 days in vivo low blood sugars. Later, baby was discharged. Child has normal milestones. OGTT done postpartum, which was within normal limits.
Okay.
The postpartum limits were normal.
Okay. So,
ma'am,
there is no active cesarean section, which was done on her.
Ji, ma'am.
Any other okay, moving ahead, let's talk about all investigations which you did in this case. Moving ahead. Okay. On exam, let's hear the examination finding. Yeah.
Ma'am, she was well built. Her present weight was 80 kg. Pre-pregnancy weight was 65 kg. Pre-pregnancy BMI was 27.06.
So how much should be the normal BMI for any women? Like when do you call it overweight?
Ma'am, normal 18.5 to 25, 24.9.
Yeah.
Overweight from 25 to 29.9.
Yes.
Ma'am, she lies in the overweight age group.
Okay, good.
Category.
Oh, yeah, good.
Ma'am, she has gained 15 kg weight during this pregnancy.
How much you would have recommended her to gain weight in this pregnancy?
Ma'am, 6.8 to 11.3 for this BMI.
Right. Rest of the things
Ma'am, rest of the things were all normal.
Okay, moving ahead. Okay.
Ma'am, on inspection, abdomen was uniformly distended. Flanks were full. Umbilicus in midline and everted. Linea nigra stria gravidorum and previous phalansteal scar seen.
Okay.
On palpation, fundal height was 36 weeks. Symphysiofundal height 37 centimeter.
So how much it should have been there, symphysiofundal height, and what is its relevance in any antenatal women?
Ma'am, in patients with large for gestational age.
Yeah. How much should it be there?
Ma'am, it should normally it should correspond with
Is this
gestational age.
normal? 37 weeks, 37 centimeter at 36 weeks?
No, ma'am, it is large for gestational age.
So how much should it be there?
Ma'am, it should be 36 centimeter.
तो एक ही सेंटीमीटर तो है, कितना डिस्पैरिटी के लिए how much centimeter more or less it should be there?
Ma'am,
Disparity of how many centimeter?
Ma'am,
1 centimeter तो थोड़ा error भी हो सकता है ना? And you said that she is overweight also, so it can be there. So I think it can be taken as normal, but suppose for IUGR, it's where symphysiofundal height is important. Some people will think it's सब कुछ ultrasound बताएगा, symphysiofundal height is not important. It is important for monitoring the fetal growth. Yes, and for IUGR also it is relevant. More than 3 centimeter disparity is there, then you call it a IUGR.
IUGR.
So abdominal circumference may also not be very reliable, as you said that she is overweight, and as she's we don't know the ultrasound report, but she's complaining of polydipsia, polyuria. So let us see what I think subsequently we will tell us about the ultrasound report. आगे बढ़ो. So what was the presentation of this patient? Cephalic or?
Ma'am, cephalic presentation.
Okay. So you did an antenatal examination, cephalic presentation, fetal heart, everything was normal.
Normal.
Okay. What investigation? Let's not come on to investigation, what you did. Let's hide that slide. So what investigation do you order in this women?
Ma'am, first of all, baseline investigations, CBC, which includes HB, TLC count, platelet count, KFT, LFT, sodium, potassium.
Why KFT and LFT? Tell me the reason for sending each. She is coming. This is going to be her first investigation, and she has come to you for the first time. So if you are doing renal function and liver function, what do you think? You have something in your mind for which you are doing it?
Ma'am, KFT, maybe she's having pre-gestational diabetes, type 2 diabetes, as she is having very high blood sugars. We have to see a serum creatinine in KFT. Maybe it is raised, associated nephropathy to rule out.
Okay.
Ma'am, and LFT, ma'am, LFT is done to see associated preeclampsia. As GDM is highly associated with preeclampsia.
Okay, so what, did she have a high blood pressure as well?
No, ma'am, it was normal.
Can we ignore that investigation, or we have to do it? So your question for, like, you will have to see that do we have to do LFT and RFT in all cases? And if yes, then why? You will see this. You will have to do this study on your own and find out, do we have to do or we can ignore it? Right. और क्या investigation किया?
Ma'am, sodium, potassium.
Okay. Okay. क्यों? तुमने क्या सोचा उसको? क्या हो सकता है sodium, potassium?
Ma'am, maybe she is having diabetic ketoacidosis. She is going towards that.
Acha. So to diagnose diabetic ketoacidosis, how much sugar, blood sugar level on which she develops diabetic?
Ma'am, 250 milligram per.
So किसी भी occasion पे इसका
इतना. But in pregnancy, it is the low level. It is even the low level on which diabetic ketoacidosis can occur.
Okay. So okay. What else you did?
Ma'am, routine urine examination.
Right. Very good.
Ma'am, we will see urine for ketones.
Okay.
urine for
Right.
ketones, ma'am.
Right, good.
Ma'am, ma'am, ABG analysis, ma'am.
क्यों भाई, क्यों ये सिक पेशेंट है, एबीजी एनालिसिस इसकी करनी है? अभी कोई सिक तो नहीं है, ये तो अच्छी भली दिख रही है ना। तो एबीजी एनालिसिस सब में करनी है? दिस इज अगेन अ क्वेश्चन फॉर यू टू फाइंड आउट।
Ma'am, if she is diabetic
तुम्हारे
ketoacidosis,
अस्पताल में फ्री हो रहा है तो चलो एक बार ब्लड निकाल के ये भी करा ले, ये भी करा ले। एवरी इन्वेस्टिगेशन you will have to justify. So
Ma'am,
in exam, be prepared for that. ABG analysis in a normal patient, normal case, and potassium, sodium in a normal case, routinely we don't do. ठीक है?
ma'am, it is done in diabetic ketoacidosis, not in
Yes.
normal
So
pregnancy.
why are you thinking in terms of diabetic ketoacidosis when she does not have anything in favor? Number one. Number two, what are the features of diabetic ketoacidosis? Clinical features of diabetic ketoacidosis.
Ma'am, polydipsia. Ma'am, she is having thirst. Polyuria. Ma'am, abdominal pain.
Or?
Ma'am,
acidosis mein?
if severe, she may be having confusion.
Yes, confusion. Yes. Sometimes they become semi-comatose or pass into coma also. Confusion.
Altered sensorium.
Yes, yes.
Ma'am, they may have ketotic
very good.
breathing.
Usually they can have ketotic smell also before they
abdominal pain.
Yes, abdominal pain. So another point for you to study is what are the clinical features of ketoacidosis in pregnancy. ठीक है? So moving ahead, what are other things you did? आगे बढ़ो, और क्या investigate? Let's see the investigation which you did in your case. Let's see that. Okay. So you did COVID also. Routinely we are doing these days, whosoever is admitted. Otherwise there is no need. Anyway, chalo, theek hai. USG. Now tell me, in any case, ek cheez ye batao, you said that she had a raised HbA1c level. So how much is the normal range now? So HbA1c normal kitna hota hai? और pregnancy में क्या ये affect हो सकता है?
Ma'am, in normal pregnancy, it is less than 5.7. Ma'am, there occurs decrease in HbA1c level because RBC turnover rate is increased in pregnancy. That is
why it is decreased in pregnancy?
Ma'am, RBC turnover is increased in pregnancy.
Most of our women, they are anemic also.
So this is not a sensitive test for monitoring her glycemic control.
If I ask you, how will you differentiate whether it was type 2 diabetes or gestational diabetes? Is it possible for you to differentiate the two?
Ma'am,
having you done the sugar estimation in mid-trimester?
Ma'am, if it is more than 6.5, then it is labeled as type 2 diabetes.
Good. So here it is 6.8. What will you label her now?
Sir, ma'am, maybe she is having type 2 diabetes.
Yes.
As she has, as they have missed her in the first trimester.
Doesn't matter. Let's not blame anyone, but it was missed. So whenever you tell anything, one more point to tell you that we should not blame anyone. It was missed. You can say that in first trimester, her blood sugar estimation was missed. कभी भी हम किसी को नहीं blame करते हैं कि किसी ने नहीं किया, क्यों नहीं किया. Let's talk in that term कि it was missed. ठीक है. आगे बताओ. So ultrasound was done when?
Ma'am, it was done on the day of admission. These are all the investigation is done on the day of admission.
My question to you is, how frequently should you do ultrasonography in a case of diabetes with pregnancy, be it GDM or
type 2 diabetes mellitus?
Yes.
Ma'am,
it frequently or क्यों करना है?
Ma'am, for 4 weekly from 28 to 36 weeks to assess fetal growth as well as amniotic fluid assessment.
Okay. कब तक? Up to
36 weeks, ma'am.
उसके बाद
मैम
36
उसके बाद
3 to 4 weeks है
weekly,
for
4
assessing. If you want to assess the growth, you do an ultrasound at 3 to 4 weeks.
4 weeks interval,
Don't
ma'am.
start so early कि बिल्कुल early से, but after 28 to
8
30
weeks.
yes, in third trimester it is more important to assess the growth. And what else? What are the indications of doing other indications of doing ultrasonography in a case of diabetes with pregnancy?
Ma'am, color Doppler ma'am, to rule out
पहला तो ये बताओ कि जब क्या इसमें एनॉमली स्कैन की कोई इंपॉर्टेंस है, जेस्टेशनल डायबिटीज में कुछ है या नहीं है, और टाइप 2 डायबिटीज?
Ma'am, from the first trimester you are saying?
No, in anomaly scan. We do routinely, but in condition it is more important, and why?
Ma'am, in which nuchal translucency is increased more than 3.5 in first trimester.
Okay, or?
Ma'am, or
type 2 just diabetes.
Ma'am, pre-gestational diabetes, we have to do it.
So what anomalies, congenital anomaly do we get in a case of gestational, in case of type 2 diabetes with pregnancy?
Ma'am, most common
associated with anomaly? If yes, what all anomaly?
Ma'am, most common anomaly is CVS anomaly, followed by CNS anomaly. And among CVS anomalies, most common is VSD.
Okay.
Ma'am, ASD is also found, and transposition of great arteries. That is specific anomalies among CVS anomalies.
Okay.
Ma'am, other CNS anomalies, neural tube defects, meningomyelocele, encephalocele, and encephaly.
Okay.
Skeletal anomalies, sacral agenesis, which is caudal regression syndrome.
Okay, that is specific for diabetes.
Specific overall, ma'am, overall specific anomaly.
Yes, very good.
Ma'am, renal anomalies, cystic kidneys, renal agenesis, hydronephrosis. Ma'am, gastrointestinal, rectal, anorectal agenesis, duodenal atresia.
Okay. So in third trimester, like you have done your USG at this point, gestational age. So when you will request for second USG in this particular case where you've done one, color Doppler, everything came out to be normal.
Ma'am,
in other words, just tell me, how do you monitor antenatal monitoring of a case who is been diagnosed as diabetes with pregnancy? Antenatal monitoring. You have already spoken many things, just a revision.
Ma'am, we will advise her next to USG weekly, ma'am.
अच्छा, नहीं, पहले क्लिनिकल कुछ कर लेते हैं, उसका एंटीनेटल मॉनिटरिंग में वेट गेन देख लेते हैं, फंडल हाइट तुमने अभी बताया है वो देख लेते हैं, फिर आते हैं अल्ट्रासोनोग्राफी, यू हैव सेड टू मॉनिटर फीटल ग्रोथ एंड all, and fetal well-being as well. Any other investigation would you like to do? Sorry, antenatal monitoring test. This patient is
on admission, ma'am, as she is admitted patient, we can do non-NST test routinely.
Yes. So,
biophysical profile.
When would you like to do a biophysical profile, and why?
Ma'am, bi-weekly.
But everything,
if the NST test was found to be abnormal, like we will advise her then BPP, biophysical profile.
में एक और important point भूल गई हो, patient admit है, we said that weight gain देख लेते हैं, fundal height देख लेते हैं. एक बहुत important चीज है जो हम लोग नहीं, अभी तुमने नहीं बताया, बताओ क्या और उसको बोलना है. What else would you like to do as a part of antenatal fetal monitoring?
Daily fetal movement count. Daily fetal.
Yes. Daily fetal movement count. It is very important. We should never miss. Why? Because we are not there with the patient 24 hours, but she is with her baby 24 hours, isn't it? ये statement है कि 24 hours she is there with her baby. She knows her baby better than us. She is expert of her baby. So daily fetal movement count, we should never ever miss in any women. That daily fetal movement count is very important. So I will request others also to ask before we go on to planning of delivery and all.
Go ahead. Go ahead. Please proceed. Please proceed.
Okay, so others they are not asking. Okay, so how long do you want? What नहीं अब तो इसका थोड़ा management plan बताओ. What management plan you will do for this case? Management plan. She is with you now, and now how you will have to manage her.
Ma'am, as she was on oral hypoglycemic agent,
Yes.
and she was not controlled on that medication, we will shift her on insulin. As she is near term, we will start her on insulin either twice daily regime or 4 regime.
Okay. So how much
And
was
monitor
her
her
sugar? How much was
her blood sugar fasting was 120 milligram.
And
And
postprandial?
postprandial was 190.
190. Okay, so how will you decide the dose of insulin for her?
Ma'am, as per gestational age and as per gestational age and as per her weight gain.
Okay. नहीं अभी इसमें शुगर के हिसाब से करोगी ना बेटा?
And as per glycemic control.
So how much should you start with?
Ma'am, as per guideline, we will start her 0.8 kg per day. 0.8 unit per kg per day.
Okay, so how much will it come to be as? And which insulin will you give her? Which insulin?
Ma'am, regular insulin as well as intermediate acting insulin, because she is having both blood sugars during
So
fasting as well as postprandial.
30-70, isn't it?
Ji, ma'am, start
insulin premix 30-70 you will give. Which route?
Ma'am, subcutaneous route.
So will you teach your patient how to inject subcutaneous, or there is no need? Some sister will inject her insulin.
Ma'am, infusion pumps she can also use insulin infusion pumps.
Is it available routinely?
Ma'am, that's not available.
वो बताओ पहले. Subcutaneous insulin लगाना है उसको, ठीक है? Sister can teach her also, because with COVID and all, duty maybe staff is limited, but she will monitor her sugar. Self monitoring she can do in hospital also, and she can inject. So ये बताओ, मतलब there are people who can teach her how to give a subcutaneous injection. Which site? Can she give it on abdomen, which is routinely given?
Ma'am, it can be given even on thigh.
Okay. Abdomen पे दे सकते हैं या नहीं?
Ma'am, दे सकते हैं.
अब again another point, you will have to go and check it. कि क्या, what is the relevance of teaching the patient how to give insulin, how it is important, and which place is she going to choose for giving insulin injection for its effectiveness. Sometimes, insulin is not effective because it is not properly given. So that is one point we should see when the patient is not getting controlled on insulin. Any other thing you will see in your case? Because now you have started her on insulin. So अब बताओ इसकी monitoring कब करनी है? कैसे करना है?
Ma'am, it can be done in the fasting blood sugar, after breakfast, before lunch, after lunch 2 hours.
जैसे मैंने आज शुरू की, तो हमको कब करना है? आज ही करने लगना है कि फास्टिंग पोस्टपेरेंडियल सब?
Ma'am, if we have started insulin today, we will start it from tomorrow morning.
Okay. But what does the guideline, national guideline tells us, which you are going to read today itself? It has a flow chart And that says that you started, patient is not getting controlled on medical nutritional therapy. You have started her on insulin. On third day, you will have to do a fasting blood sugar and 2-hour postprandial glucose. So on third day, because immediate effect may not come, and every time you are pricking the patient, taking out the blood. So once you have started, do it on third day. On third day, what is the report? Accordingly, you continue with the same dose, or you may have
or
to
intensify it.
increase. Okay. So I don't think you will know everything today itself, but once you read this, you will realize how to monitor. Otherwise, like, you can tell, how do you monitor your case on who is on insulin? जो अब तक तुम करते आए हो वो बताओ.
Ma'am, we are doing it in the fasting, after breakfast 2 hours, before lunch,
Okay.
after lunch 2 hours, and before dinner and after dinner 2 hours.
Okay. So once your patient is controlled, and now you are able to achieve the goal of keeping the blood sugar within normal range. So when are you going to terminate this pregnancy?
Ma'am, if she is
And you are
well
doing a good
controlled on insulin, we can we can terminate her between 38 to 39 plus 6 days.
Okay. So, and which should be the mode of delivery in your case?
Ma'am, mode of delivery in my case is elective cesarean section.
Why?
Ma'am, she is 38 years old. She has previous LSCS. And at 36 weeks gestation, she has 3.3690 baby weight.
So, like, thinking that she has a big size baby and her age is also 38, you are going to perform a elective
cesarean section.
So how do you prepare your case for elective cesarean section? Right from the pre-operative preparation, consent of the case, moving her to operation.
Ma'am, first we will do, ma'am, first of all, we do proper anesthetic consultation day before surgery.
Okay.
We will take consent from the patient, proper consent in view of high risk consent.
क्या लोगी? What will exactly you will tell the patient and her attendant? High risk क्या लोगी? You are going to die tomorrow when we operate?
No, ma'am.
What will you tell them?
Maybe she may be having PPS. She may need blood transfusion.
No, you don't counsel the patient like this scary scene. You tell her that, you talk to her in a very friendly way. Tell her that, see, we are going to operate you tomorrow in view of your good size baby, and you already had undergone cesarean section. So what all things you want to us? So Dr. Ashish is probably saying that he has to go for some other webinar. Dr. Rizwana, please address that issue.
Yeah.
Dr. Ashish is saying that I have another webinar, so I have to leave now. Thanks a lot to everyone. Wonderful program.
Yeah, thank you, Dr. Ashish.
Dr. Ashish, thank you very much for joining us. Dr. Ashish, if you can hear me, thanks a lot for being with us.
And we would have really liked his inputs.
Dr. Ashish, before I think you leave, you can give your input, and that will be, we value your inputs.
Madam Ashish are not there.
Oh, he has already gone. Doesn't matter. Doesn't matter. So we should carry on. So how will you counsel your case? Coming back to Muzammil.
Okay, ma'am.
And just feel comfortable. How are you going to counsel her? तो जब अपना counseling का और एक तो ये रहता है कि you make the patient comfortable. The husband partner should be comfortable, and then you open the dialogue with words like, how are you doing? How are you? We have planned a cesarean section for you tomorrow at around 9 o'clock. So do you want to ask us anything? then she will ask you something, then she say that you can tell her that most of the cases they go uneventful, but as you have diabetes, you can have your sugar level can rise, but if you are comfortable, you are not tense, that is unlikely, but during surgery we try our best to do everything, but sometimes you can have then you can talk about the pph. Once she is prepared, now she has also certain questions she has discussed, then you can open up and tell her, but you can always tell that we are there for you for anything, but there are certain things sometimes which is not in our hand, and then they will not fight with you if they have some complications. Like कभी कभी ये होता है कि हम जब सिजेरियन कर रहे होते हैं और कुछ कॉम्प्लिकेशन हो जाता है तो वो सब तुम्हारे ऊपर चढ़ जाएंगे, बट इफ यू हैव ऑलरेडी स्पोकन टू देम दैट these problems can rarely happen, we are prepared to handle it, but sometimes things are not in our hands. Sometimes, they have very rarely amniotic fluid embolism, which you don't know. So you should prepare your patient, but at the same time, don't scare them by telling you can have PPH, you can even die on the operation table, and all those things should be avoided. But counseling should be proper. Again, Muzammil, I'll request you to see some videos on the counseling session. WHO, they have uploaded videos, and many people, the counseling session video they upload for students to see, and I think these are very important. अक्सर ना बच्चे ये सोचते हैं ये सब क्या, ये सब तो पीएसएम और उन लोगों की बात है, बोलो बोलो, हम लोग का तो काम है सिर्फ मरीज को डायग्नोसिस करना, सर्जरी करना, पोस्ट ऑप केयर करना. नहीं, ऐसा नहीं है. Whenever you have any case, the case is as a whole in front of you, and the family is important, the case is important. So all these points are very important, and every doctor should learn. Coming back to you, Muzammil, और क्या करोगी? Just switch on your camera and we can talk.
Ma'am, advise
your pleasant face. Yes.
Ma'am, advise her to take ma'am, we will advise her to take insulin insulin at the bedtime, proper meal at the bedtime, and we will advise her to emit morning dose of insulin.
You
and
tell her to
blood
take
sugar fasting in the morning. We will
skip the morning dose
dose
या
of
उसको लगा
insulin.
लेना है? नाश्ता तो करेगी नहीं सुबह में?
Ma'am, we will skip the morning dose of insulin and do blood sugar fasting.
Yes.
And ma'am, keep her as the first case in the morning for elective section as she is fasting.
Okay. And what else? Like drip लगाओगे with or?
Ma'am, we will start her IV infusion normal saline.
Normal saline or with insulin?
Ma'am, if her blood sugars are deranged, if she may need insulin, then we start her on insulin. Or if her blood sugars are deranged.
Accordingly. So
according to blood sugars.
Well, yes, you monitor according to blood sugar.
Blood sugars
as a first case and starter. Now coming on to what all complication this baby can have. We have taken out the baby. What all problems can be there at before that, if we have to operate her at 38 weeks, you said that 38 or between 38 to 39.
39 plus 60.
Give DEXA coverage before taking her up for an elective cesarean section?
Ma'am, as she is our admitted patient, for the safer side, we can give injection betamethasone or dexamethasone her because this is the period at which there is high risk of chances of IUD. Stillbirth. Ma'am, stillbirth.
So DEXA coverage DEXA coverage क्यों करना है?
Ma'am, for fetal to attain the fetal maturity, because they have these babies have a late fetal maturity, delayed lung maturity.
If you are operating anyone before 39 weeks, you give DEXA, isn't it? You give DEXA coverage, and here the chance of having respiratory distress is more.
Distress is more because they have delayed lung maturity.
Okay, so one more thing we missed. आई एम सॉरी, लाइक हमको वापस से एंटीनेटल पे जाना है। एक इम्पॉर्टेंट चीज और तुमने मिस की है, आई ऑल्सो फॉरगॉट टू आस्क यू, जब 24 वीक्स पे इको इनका कराना है या नहीं, डायबिटीज विद प्रेगनेंसी?
मैम इको हम तभी करना है अगर इफ शी इज प्रीजेस्टेशनल डायबिटीज और इफ
ये तो तुम्हारी
प्रीजेस्टेशनल मैम, प्रीजेस्टेशनल type 2 diabetes, or if she is having nuchal translucency more than 3 millimeter,
to do with that.
and because ma'am, if it is increased more than 3.3 mm, because they have the higher chances of cardiovascular anomalies.
Okay. Dr. हम eco भूल गए थे. Note it down that eco should have been done at 24 weeks. Why? I remembered it just now, that if the patient, like after delivery, what all things you will see in baby, pediatrician को और क्या क्या देखना चाहिए?
Ma'am, check for neonatal hypoglycemia.
Yes, very important. So when do you call it a neonatal hypoglycemia? कितना sugar level पे?
Ma'am, in normal weight babies, if it is less than 45, and in IUGR babies, if it is less than 54 in gestational diabetic baby.
Okay, so they should see that. और क्या देखने को कहेंगे?
When do you
Ma'am, bilirubin.
हाँ?
Ma'am, check for hyperbilirubinemia.
Why? Later on in
Later on, ma'am.
Yes. और क्या क्या complications होते हैं?
Ma'am, check for anomaly. Check for to rule out any anomaly.
Okay, at birth, ठीक है?
At birth, ma'am.
और hypoglycemia.
Hypoglycemia.
Hypothermia होता है? हो सकता है?
जी मैम.
हाइपोथर्मिया तुम्हारे कश्मीर में तो ज्यादा रिस्क होगी हाइपोथर्मिया की, बट होता है। और हाइपोग्लाइसीमिया
मैम, हाइपोग्लाइसीमिया,
कुछ कैल्शियम और इन सब का,
हाइपोकैल्सीमिया, हाइपोमैग्नीशियमिया.
ओके
मैम, they are at high risk of polycythemia.
Yes.
Neonatal seizures. Neonatal seizures, hyperbilirubinemia.
Okay. And in mother, what all complication post-operative can be there?
Ma'am, they can have high chances of peripheral infections.
Okay. Okay. And what about insulin which she was getting? अभी तो इसको इंसुलिन पे रखा था ना, अब सिजेरियन हो गया, डिलीवरी हो गई, अब इंसुलिन और शुगर की मॉनिटरिंग कैसे करेंगे?
Ma'am, first of all, we do it after 2 hourly for 3 consecutive readings. If they come normal, then we do it 4 hourly for next 4 hours, 24 hours.
का क्या करें जो डोज उसको लग रही
Ma'am, if she has normal blood sugars, then we will not start her on insulin. We will monitor her blood sugars.
Okay. So anything else left? Dr. Rizwana, आप कुछ कह रही थी. I'm sorry, हमने आपको.
Yes. I want.
Professor Seema Madam has very comprehensively and very deftly examined the student. She's a seasoned examiner, mashallah.
No, I wish I could have done my job better. अब बीच में छोड़ गया एक, जैसे इको नहीं करा, तो वो था ना कि वो
you still managed to round it off very nicely. Dr. Muzaffil, very nicely you answered the exam. I have a very good impression that you will fare well also in your examination, inshallah.
It was a really very good activity for us, and I'm always there for you. It's not only this platform that we can help each other. Otherwise, also I am always there for you.
Thank you very much, Dr. Seema.
कश्मीर के लिए तुम्हारा दिल है, जान है.
An investigation antenatal period that is a recommendation. You know, a mid-trimester urine culture is recommended in accordance even with urine examination, because these patients usually tend to develop more asymptomatic bacteriuria, which we need to be very careful about.
Yes.
And now, since you have very professionally managed this patient and delivered the baby, mother and baby have gone home, she does not want to get pregnant. What contraception will you advise for this woman?
Ma'am, ideal is barred contraception.
Sorry?
Ma'am, ideal barred contraception.
Why not PPIUCD?
Ma'am, she can progesterone only pills. Combined.
Why not PPIUCD? I'm asking you.
What is PPIUCD, beta? What is PPIUCD? PPIUCD.
Postpartum insertion of
contraceptive device.
intrauterine contraceptive device.
Ma'am, they are at the high
Device में
chance.
तो
Ma'am,
सबसे
they are at the
device
high
है.
risk of puerperal infections.
No, why? She is not infected.
No.
ऐसा नहीं है. अच्छा ये अब तुम आज तुम्हारा another homework for you. You will have to see WHO medical eligibility criteria of PP of IUCD. You will have to read what is PPIUCD and in which case it is contraindicated. Diabetes, if it is controlled, you can apply it.
And in fact, this patient, pre-cesarean section counseling session may you can offer this to her, and post just after you finish the procedure, in fact, she will be in a better position to accept this contraceptive method.
Yes.
You know? Yes.
Very
So,
good.
and but you have to also counsel her. Expulsion rate ka thoda zyada hai compared to interval. But she will be more acceptive of this because she has gone to pregnancy. एक ही sitting में contraception भी हो जाएगा. You have barrier method, you have PPIUCD. What else you can offer her?
Yes, and you can always tell her that if any problem, we are there to help you and we'll remove it.
Right.
अगर आपको नहीं सूट करेगा हम निकाल देंगे इसको. लगाना बेहतर है उसको contraception के लिए.
Suppose this woman was hypertensive, diabetic. She was diabetic, type 1 or type 2 diabetes, and she had vasculopathy. She had hypertension. She did not want barrier method. Husband is not cooperative. She doesn't want PPIUCD. If you had to give her hormones, what would you give her? And why?
Ma'am, progesterone only pills.
Okay. Why wouldn't you give her estrogen?
Ma'am, because she is hypertensive.
What will it do? What will it predispose to?
Ma'am, it will predispose to thromboembolic complications.
Very good. Very good. And how many children does she have?
Ma'am, she is now she is with 2 children.
She is now with 2 children. According to family planning, if it is her option, you could also say it. You can counsel her because ultimately the option is hers, isn't it?
But
Hum
these
do, hamare do, right?
Diabetic babies, sometimes they don't behave well.
They don't behave
They
well.
don't behave well. So if she has undergone a permanent method, that can
So
be a
permanent
problem.
method ka sometimes patients come. So counseling mein contraception ka, sterilization ka, sometimes people come and they say, "Nahi, karo." So you have to counsel the
There is a
patients very
guideline that the
pertinently
second child should be
about
at
this. This
least
is how
2
you will be
years
able
old.
to counsel your patient and tell her ki what you can expect complications in baby.
No, permanent like contraception, the second 2 child norm, the second child should be 2 years old. So this is a newborn, so there is a risk.
Yes. So counseling plays, like Professor Seema Madam said, it plays a very, very big role. And I think, you know, some to a certain extent, even counseling, it is better to do counseling. They say don't put a table between the physician and the patient. We sit face to face. The patient feels she's talking to a friend.
Yes.
She's more receptive to your input and she's more cooperative. And जैसे मैडम ने बोला फिर आपके सर पे नहीं आता है in the end.
नहीं और ना जब काउंसलिंग करते हैं तो हम लोग ना we do more talking than listening. We should be a good listener.
Right.
Every doctor
Yes.
should be a good listener rather than a good talker. Just be a good talker. That doesn't help much. जब हम उनकी पूरी सुन के और अपना ओपिनियन दें या उनसे बात आगे बढ़ाएं तो वो हमेशा ज्यादा हेल्प करता है.
What is the last question from my side? What is the when a woman has had a gestational diabetes pregnancy, and you know, they say pregnancy is the window of opportunity, especially in our India, where women come to the doctor when they are pregnant and usually they don't go for any other reason. So you have a gestational diabetic mother. What is the future prognosis of this lady? Pregnancy has unraveled diabetes in her. So what is the future? What is the future course? What will you counsel her for?
Ma'am, I didn't get it.
See, this patient was 155 centimeters. She was 27 plus BMI, right? She had gestational diabetes in the first pregnancy and she got it in the second pregnancy as well. So as she lives on, does she have a chance of developing diabetes later in life?
G, ma'am, type 2 diabetes mellitus, cardiovascular diseases.
Yes, what are the
metabolic
chances?
syndrome. Ma'am, 50%.
If a woman has gestation,
Ma'am, 50%.
50%. Yes. So before she goes home after all this, what will you counsel her? What will you tell her?
Ma'am,
What
we will
to
counsel
do?
her about lifestyle modification, which will
Very
reduce
good.
her
Good.
weight loss, which will reduce her weight. That
Yes.
will reduce the risk of type 2 diabetes, mellitus, and cardiovascular disease in the future.
Right.
We will counsel her about the importance of doing screening for glucose intolerance in the future, in order to detect diabetes mellitus at
Very
the
important.
earliest.
Yes.
Ji, ma'am. Ma'am, we will counsel her. We will counsel her about the importance of contraception. Ma'am, before planning,
Okay.
before
Your
planning of
screening of blood
next
sugar,
pregnancy.
what will you advise her?
Ma'am, I will advise her to
Yes.
do
Pre-pregnancy OGTT has to be done.
that is necessary, ma'am, in order to achieve adequate glycemic
That is
control before
pre-pregnancy.
planning a future pregnancy.
When will you do it?
Ma'am, we will do it at 6 to 8 weeks after
And in
post-delivery.
between, what
If it
will
is
you do?
negative, then do it 1 to 3 yearly.
Now your patient is, you have done a cesarean, isn't it? How will you monitor her blood sugar? Can she go into hypoglycemia or whatever complications can she have immediate post-op complications? What can happen?
Ma'am, in patient, ma'am, she can have episodes of hypoglycemia as well. She may have
so you have to monitor both the mother and the baby.
Mother as well as neonatal blood sugars, ma'am.
After how much time? How?
Ma'am, in mother, we do it too early for 3 consecutive readings. If it comes normal, then do it 4 hourly up to 24 hours. Then, ma'am, if all these readings were normal, then we do it fasting and then postprandial when she's on full orals.
And then?
And in neonate, we monitor it immediately half hour after birth. Then after every 1 to 2 hourly, ma'am. Up to 3 consecutive normal readings in baby, ma'am.
Dr. Muzammil, any
I said that was really a very, very good discussion. I thoroughly enjoyed, and I have asked her to read many things. And Dr. Rizwana, you take an account that she reads it and tells you that she has read everything, she has checked.
Yes, thank you, Dr. Seema.
And when you read about GDM, also read how to manage shoulder dystocia. Why these babies are more at risk of shoulder dystocia. यहाँ तो तुमने cesarean plan कर लिया. But if you leave them for a normal vaginal delivery, or they have come in labor and they are going to deliver, why the risk of shoulder dystocia is there?
Ma'am, because they are more prone to shoulder. Ma'am, they have fat deposition. These babies have fat deposition in shoulders and trunk.
It is called preferential fat.
Preferential, ma'am. This is peculiar in gestational diabetes. They have peculiar fat deposition in shoulders and trunk.
Why? Why there is fat deposition? Are they getting food? That is why they are having?
Ma'am, because of hyperinsulinemia. Because of hyperinsulinemia, this insulin acts as growth factor, insulin-like growth factor 1. That causes,
if mother's blood sugar is not controlled,
the
more sugar will pass through the placenta, maternal hyperglycemia leading to fetal
hyperinsulinemia.
There will be insulin release, and insulin has a property of growth-like factor. So it will cause those sugar which will be deposited in the form of fat, and more in the body and trunk, more
more
fat
in the trunk and the fat.
Head, around the head and brain, the fat doesn't get deposited. The head will come out, but shoulder will be stuck at brim, causing shoulder dystocia. So this is another point that you are going to read, that why these babies are fat, obese, chubby. क्यों होते हैं diabetic mother के baby? ठीक है?
So I think any inputs from Dr. Mahapatra, anyone attending, any other teachers?
Yes. I will mute myself now.
Dr. Seema, thank you very much for an excellent grilling session.
Thank you so much.
It was all basics, but the younger generation has already forgotten the basics. They come from the top. All complications they'll know, but basic management is something. Clinical examination, basic management is a thing of the past, I think, in the younger generation. I really appreciate your...
Dr. Masuma, both your students were good. Mashallah, both were good girls.
Thank you very much. Thank you very much. It was wonderful.
Thank you, Dr. Rizwana. I am from Jodhpur, Rajasthan. Dr. B.S. Jodha is speaking. And I really enjoyed the conversation. Dr. Seema has taken it to the heights, and Dr. Muzammil has given good answers and given the opportunity to the residents that they should prepare the cases in coming weeks to that we will be seeing in these OGTFI platforms. And I invite all of you for the next program, which is to be held on 2nd of January 2021 from the Jodhpur Medical College. Students will be presenting it, and the topic is postmenopausal bleeding. So really thanks to all the persons who has as an examiner and who has conducted this session very well. Thank you very much.
I would love to join Jodhpur. At anything happening in Jodhpur, I would love to join.
Most welcome.
My husband has graduated from Jodhpur Medical College. So,
in which year, ma'am?
Got a lifetime achievement award at Jodhpur. So I would love to join anything from Jodhpur.
In which year he passed?
Long back, 74 MBBS batch.
Okay, okay. What is his good name?
Dr. Rashid Manzoor Khan, and he got his lifetime achievement award. He is an anesthetist and intensivist. So they had a conference, national conference, in which he was conferred lifetime achievement.
Yeah, it is in year 2011. We had the anesthesia conference.
Yeah. So it will be my pleasure to attend anything that is from Jodhpur. You can send me a link, you can invite me.
Definitely.
More than
definitely, we will be.
What will be the timing, sir?
It is the same, ma'am. It is from 2 p.m. onwards till
same time.
5 p.m. Yeah, same times.
So thank you, everyone. Thank you, Dr. Jodha, also Dr. Seema, for your inputs. Really nice grilling session.
Yeah, we enjoyed it.
We really enjoyed it. Thank you, Dr. Simona.
Dr. Rizwana madam, Farat madam, Dr. Masuma.
Thank you very much. Thank you, all of you. It was wonderful. It was really wonderful. I wish we can have more sessions like that.
Very big, many more.
Inshallah. All the best to Dr. B.S. Jodha.
Thank you, ma'am. You recognized me. We had met earlier.
Yeah, we have met earlier.
Yeah, sure, ma'am. Yeah. Thank you very much.
Join the session on 2nd, inshallah.
Thank you.
Okay.
Thank you very much, doctor. I'm Sapan Shah. On behalf of Sunfarm, I would like to thank, and I would like to inform that every alternate Saturday, we have the similar kind of session. Next session is from Jodhpur, as Dr. Jodha sir has said. And after that, next session will be on 16th of January. That will be the third Saturday. So every first and third Saturday, we have alternate Saturday, we have the program.
Thank you very much.
For the benefit of PG students all over India.
Thank you. Thanks.
We have vote of thanks from Dr. Shazia. If she is present and if we have time, we can give a vote of thanks.
Hello. Hello.
Yeah.
Yes.
Hello. Am I audible?
Yes, sure.
Am I audible, ma'am?
Yes, Shazia, you are clear. And
Assalamu alaikum and good evening, everyone. I'm Dr. Shazia and I'm here to present vote of thanks. Today's webinar was indeed full of knowledge and interesting facts. It gave us deep insight into the management of certain high-risk pregnancies. Webinars in teaching form of this type are indeed need of our in this challenging time of COVID, where our UG and PG teaching has been adversely hit. I extend very hearty vote of thanks to Dr. P.C. Mohapatra, the Chief Coordinator of this teaching program. Dr. P.C. Mohapatra is a great academician and has organized and participated in innumerable academic programs throughout India. He's an esteemed orator and a prolific social activist as well. I'm grateful to Dr. Ashish Mukhopadhyay, Coordinator OGTF, for creating this teaching platform. Dr. Ashish is a great teacher and an academician par excellence. I would like to thank the organizers of the Srinagar chapter of OGTF, Professor Dr. Farhad Jabin and Professor Dr. Rizwana Habib from Department of Ops and Gynae GMC Srinagar. It's because of their endeavor and support that today's teaching program became a reality. I thank all the chairpersons, Professor Seema Hakim, Professor Sudha Sharma, Professor Nighat Firdos, Professor Ifat Tara, Professor Abida Ahmed, Professor Tabassum Parvez, Dr. Mehbooba and Dr. Simona for sparing their valuable time and making this session lively. I'm really indebted to all the speakers, Professor Dr. Masuma Rizvi, Professor Dr. Samia Mufti, Dr. Iman and Dr. Muzammil. Thank you for sharing your knowledge and enlightening us. Thank you all the participants for making this webinar successful. Finally, I would like to express my deep gratitude to Team Sun Pharma, who have been the backbone of this event. They are always on the forefront in organizing such teaching events. Thank you, everyone. Have a great evening. Assalamu alaikum.
Assalam. Thank you.
Happy New Year, everyone. And with that, we wind up the session. Thank you.